All. Myself, Dr. Archana Khare, welcome you all for the first CME of the year on the behalf of my team. It's always difficult to interpret the reports of ultrasound. It can comes, if it comes growth percentile less than 10%, oh no, what shall I do? If it's come like growth percentile less than 3%, oh God, what next? This is the most important question in mind of every obstetrician and will play a great role to save these unborn FGR babies in a good time and in a good condition. For this session, we are privileged to have Dr. Ajit Gandhi sir and Dr. Sumit Chamaria sir as a chairperson. Both are fetal medicine experts from our society. They don't need any formal introduction to us. I welcome you, sir. Please, Dr. Gandhi sir and Dr. Sumit Chamaria. Take mic.
April to discuss an equally hot topic, which is a day-to-day concern for all of us. Well, see, if you look back some 15-20 years ago, the life of a fetus was more of a fetal medicine than a fetal medicine. Dr. Lilly, in 1963, he coined the term fetal medicine when he started a training course in intrauterine transfusion somewhere in 63, and then the word fetal medicine came into existence. Now, the very purpose of the fetal medicine is to facilitate the entry of the fetus from womb to this world. For a sick fetus, for a problematic fetus, we try to bring this fetus in a good shape in this world. Around the turn of this century, we got a very nice gadget, the Doppler. So far, till before that, the fetal assessment was very inaccurate and gross, I would say. If you remember, those who are seniors in this crowd, we used to measure the symphysis pubis distance and then abdominal girth and try to get the fetal weight. And it used to go wrong by almost a kg and half kg and so. And we used to miss a lot of fetuses who were growth restricted and stillbirth, meconium staining, birth asphyxia was quite a, not I would say common, but then it was a fairly common event that used to be. Now all this has changed in last 15-20 years with the advent of the ultrasound and the Doppler. Doppler is especially more helpful in assessing the fetus, the oxygenation or the identifying the hypoxic fetus. Today we have two great experts in this field. I have the privilege to introduce Dr. Bijoy Balakrishnan. He has graduated from Karnataka University in 1999. He is MS OBGY 2005 from Orissa. He is head of the fetal medicine unit of CIMAR since 2007. This is the first fetal medicine unit of Kerala. He is president of Kerala chapter of Society for Fetal Medicine. He has been invited as a speaker in numerous conferences, national as well as international. He is winner of the Kalyani Devi Award for the best paper and Kamal Bakshi Award for best presentation. He is organizing secretary for the Pericon series and Society for Fetal Medicine in 2014. He has 17 publications in his credit. Those are all publications are in index journals. He is practicing fetal medicine for last 15 years. He is well versed in all the fetal medicine procedures like amniocentesis, CVS, fetal blood sampling, shunting and all that. May I have the privilege to present you Dr. Bijay Balakrishnan. Over to you, sir.
Good morning, everyone, and let me start by thanking the organizers for giving me this opportunity to be here. When I told my wife that I'm going to travel for 600 or 700 odd kilometers on the road to reach a place called Solapur, she did not ask me why, because she knows that there are three places in India where I will always go for a talk. One is Solapur, I'll tell you why. The other is Bijapur, and the other place is Berhampur. Now, why Solapur was because I graduated, as you saw, from Karnataka University. They didn't mention where, and that is Bijapur. And whenever there was a weekend and there was a new movie in town, me and my roommates used to pick up our bikes and come to Solapur and then watch a movie and then head back. So that's why Solapur has got a lot of memories for me. And it is not the Solapur that I see today. There was no big hotels or anything like that, but it was a nice place to come to, watch a movie, have something and go back. So that's the reason why I'm here on an Easter Sunday, and thank you for the invitation. Now, coming to the topic of learning to save the small fetus, I heard people talking about fetus less than the 10th centile. Let me just ask you something. If I tell you that you should screen for only women, for Down syndrome, only women above the age of 35, how many of you would agree? You would say it's absurd, right? But say 15 to 20 years ago, let's say 20 years ago, people used to do that. People used to only screen for Down syndrome in that age group, only for women greater than 35 years. But now we know that that's not the truth, right? We know that Down syndrome exists more in the younger age group. Am I correct or wrong? I'm correct, right? Now look at what we are doing in FGR. We are hunting for FGR in only small babies. Isn't there a similarity there? Less than 10th centile is something like women greater than 35 years of age. we are hunting for fetal growth restriction only in a small group because we know that there is an increased risk of babies having growth restriction when they are small, but forgetting that there could be babies with growth restriction that are above the 10th centile. Does that make sense to you? How many of you had a normal ultrasound in the 3rd trimester and then have found these babies dying? Everything was normal. The baby was at the 30th centile, the 40th centile, the Dopplers were normal, the AFI was good, everything was good. You call them back for 36 or 37 weeks to do a PV and decide when you want to deliver them, and by the time they become an IUD. Has that happened? And you rack your brains thinking, why? Why did I miss this? The same thing people used to do 15 years ago. 25-year-old young lady, she has a baby with Downs. How is this possible? You understanding? There is no risk involved in a baby in a woman who is less than 25 years old. She's young, she has no family history, she has a baby with Downs. So the exact same thing is happening in FGR. So the first thing that I want you to do is forget about smallness. Forget about smallness. We are not talking about smallness, and I'll tell you why. So the first thing about growth restriction is to define growth restriction, to diagnose that small baby. And for that, we have got what is known as growth charts and Doppler. I'll come to that in detail. Now, the basic error that we make while trying to find out a growth restricted fetus is we use these terms interchangeably, SGA and FGR. Now, what is SGA? SGA is nothing but smallness. It is just telling you that the fetus is small. It is a statistical definition. If you look at all the fetuses that are growing at a particular gestational age, and if you find that they fall less than the 10th centile, you would call them SGA. It's a statistical definition. It does not talk about growth restriction. It is only giving you a number, telling you that this fetus belongs to that group that is less than the 10th centile. That is SGA. But what about FGR? Now, the error that we are making is we are deriving the diagnosis of FGR from the definition of SGA. We are saying that FGR is a fetus that is less than the 10th centile and has signs of uteroplacental insufficiency. Am I correct? You're looking for FGR in that subset. But FGR is not just smallness. It is about a fetus that fails to reach its growth potential. We do not know what the growth potential of this fetus is. The baby can be at the 20th centile or the 30th centile. Maybe its growth potential is at the 50th or the 60th. We are not aware of that. But we are looking at only extreme smallness to make that diagnosis. Now, some of you might argue that, so we have not found this to be very true. We have found that babies are growing well, and most of them do well, right? So why do we need to be worried about babies that are above the 10th centile? And that's where this paper becomes very, very useful. This was a retrospective study that was done in the United Kingdom that looked at 69,000 pregnancies. And what they showed us was, in the earlier part of the gestation, growth restricted babies were extremely small. In the earlier part of the gestation, if you had growth restriction, these babies were extremely small. But towards term, 70% of the stillborn babies, normal babies, anatomically normal fetuses without any other problem, 70% of them were above the 10th centile. 70%. Can you imagine the numbers there? 70% of these fetuses were above the 10th centile. And why is that? Because when we look at the fetal weight, as soon as the fetal weight drops from less than the 50th centile, the perinatal mortality keeps on increasing. And it is highest when it falls less than the 3rd centile. So babies are truly safe only if they are above the 50th centile. But once they start dropping to less than the 50th centile, then the risk of having problems like poor perinatal outcomes and neonatal deaths are all going to increase. So here is the first basic thing that I want you to understand. Placental damage can be severe and can be mild. The severe ones are going to be less than the 10th centile, but the milder ones, the ones that are going to cause growth restriction very late in pregnancy, and sometimes these fetuses may not have time to go below the 10th centile, those are the ones that are going to be a problem for you. It is not the extremely small fetuses, because the extremely small fetuses are going to be there standing out and telling you that they have a problem. But the ones that are restricting late, because the placental damage is mild, usually less than 30%, are good enough for that fetus till around 32, 33 weeks, and after that they begin to growth restrict. So the way forward is to understand that yes, we need to look at all fetuses less than the 10th centile, but we also need to look at fetuses between the 10th and the 50th centile if you don't want to lose babies that are in that group towards term. So how do you do that? You look for signs of fetal compromise. Whenever this baby is feeling a problem or if there is hypoxia, it is going to throw out a signal, and we are going to try to identify those signals. The first one is Doppler, and I'm not going to go into detail because Dr. Pooja is going to deal with it, but I'm just going to tell you a few important points that you should understand. In Doppler, there are two distinct abnormalities that we are looking at. The first one being diagnostic Doppler abnormalities, where we use Doppler to identify growth restriction, and the second one being prognosticating Doppler abnormalities, which will tell us that, okay, this baby is going to die in utero and we have to pull this baby out. So these are two broad categories of Doppler abnormalities. And when it comes to diagnosis, we are only going to look at these three vessels. When you want to identify growth restriction, you are only going to look at these three vessels: the uterine artery, the umbilical artery, and the MCA. The uterine artery is talking about maternal supply to the fetus, all of you know that. And as the gestation progresses, the supply has to keep on getting better. So whenever you have an abnormal uterine artery, it tells you that the supply is bad. And if the baby is small, it gives you a direct reason of uteroplacental insufficiency. So it works as a diagnostic tool, and it works as a screening tool. If it is less in the first trimester, you know that this baby may growth restrict later on. And if you do an ultrasound in the third trimester, and if you find the baby is small, and if you look at the uterine artery, if it is abnormal, it becomes a diagnostic criteria telling you that this baby is small because its supply is bad. The umbilical artery tells you how good the fetal compartment of the placenta is, and as the gestation progresses, it has to get better. And if you look at the degree of damage, it is going to create an abnormality in the umbilical artery. And here I want you to remember the 30% concept. Unless the placental damage is above 30%, you're not going to get a change in the umbilical artery. When it rises to 60, it becomes absent. When it rises to 70, it becomes reversed. And that's where the 30-70 concept comes in. When a majority of the placenta is abnormal, this baby will growth restrict early because its source of nutrition is less, and therefore you will get early onset growth restriction and the umbilical artery will be abnormal. If the placental damage is less, what's going to happen? This baby will grow normally till its placenta can support it, and after that it begins to growth restrict, and therefore growth restriction happens pretty late, and the umbilical artery is usually normal. Now what if the placental damage is very less? If it is very less, the fetal weight will still be above the 10th centile, but the fetus will be experiencing signs of hypoxia, and there the umbilical artery is going to be normal. So the umbilical artery is an excellent surveillance tool. It tells you how the disease is progressing. It helps you in diagnosis, but where it fails is in mild forms of placental disease where the umbilical artery is going to be normal. So if you find a small baby in the third trimester, and if the umbilical artery is normal, it does not rule out growth restriction. And that's where the middle cerebral artery comes in. Because if the baby is experiencing a deficit in nutrition, it is also going to experience a deficit in oxygen. And that's what the middle cerebral artery will tell us. If there is hypoxia, it triggers a response within the middle cerebral artery because the fetus tries to protect its three vital organs, the heart, the brain, and the adrenals. And it dilates the supply into these particular organs, and the brain being an easier structure for us to evaluate, we can look at the middle cerebral artery and it tells us that there is hypoxia. Now the problem with the middle cerebral artery is that it becomes abnormal very late. And that's why we use another criteria called a CPR, which looks at both the umbilical artery resistance as well as the middle cerebral artery resistance. And if the ratio is abnormal, it tells us that there is a high probability of hypoxia. So for the diagnosis of growth restriction, if you find that the baby is small, 3 things you will look at. The uterine artery, if it is abnormal, it tells you the supply is bad. You look at the umbilical artery, and if it is bad, it tells you the damage is greater than 30%. You look at the MCA and CPR, and if there is hypoxia, you know that this baby is actually having a deficit in nutrition and has not reached its growth potential. Now there is another thing that we can use for diagnosis, and that is growth interval. All of you must be using growth charts, I hope, in your practice, and you must be seeing the growth velocity. Okay, so when you find that the baby's growth velocity is dropping, are you always worried? You are. But nobody tells you what is the time interval in which that growth fall is significant. Most of the definitions right now on growth interval tells us that you are going to be worried about growth restriction if there is a drop in the estimated fetal weight when it drops by around 50 centiles. So it's like from the 80th centile, if there is a drop to the 30th centile, we are going to be worried. But they don't tell you what is the time interval. Is that drop significant over a period of 2 weeks? Or is it significant over a period of 6 weeks? What is the time interval that the drop is going to be significant? Now let me show you an example here. Here you can see clearly that this baby is falling off the chart. But I'm not sure which interval is significant. And that's why I want all of you to remember this paper. What they did in this paper is that if there is a significant growth fall, as described by most of the papers, there is going to be a Doppler abnormality. And that Doppler abnormality may be in the MCA or in the CPR. So if you have a baby that is less than the 10th centile, and if you find that there is a drop in the growth velocity, plus a Doppler abnormality, that is when you're going to be worried. Now, the point in favor of the growth velocity is any fetus that is above the 10th centile and is showing a drop in the growth velocity by around 50th centile. It doesn't matter if it is above the 10th centile, you're still going to be worried. So your growth centile is important, especially in those fetuses that are above the 10th centile. So how do you diagnose FGR? You're going to divide them into 2 groups. One group, that is SGA, where the fetal weight is less than the 10th centile, and another group that is in between the 10th and the 50th centile, the so-called appropriate for gestational age fetus. Now in the SGA group, when you find that the baby is less than the 10th centile, there are 3 possibilities. It is either just a normal SGA or a constitutionally small fetus, or it is early onset growth restriction, or late onset growth restriction. So we have to divide them and understand to which of these groups they are going to be present. Now in early onset growth restriction, the growth restriction is happening early, the placental damage is more severe, therefore the umbilical artery is always going to be abnormal. So if you have a small baby with an abnormal umbilical artery, you can be very sure that you're dealing with early onset growth restriction. The problem comes in late onset in SGA, where the umbilical artery is going to be normal. So if the umbilical artery is normal, then we need to look at certain other factors. What are we going to look at? We are going to look at the uteroplacental supply, we are going to look at the uterine artery, we are also going to look at signs of hypoxia, and we are also going to look at signs of extreme smallness. So if you have a baby that is small in the 3rd trimester, you're going to look at 3 things. One is the uterine artery normal or abnormal. Is there an abnormality in the MCA or the CPR? Is the baby extremely small, that is less than the 3rd centile? If any of these 3 things are positive, you would immediately classify them as late onset growth restriction. So when you put all that together, when the umbilical artery is abnormal, it is early onset growth restriction. When either of the 3 things that I've shown on the screen are abnormal, it is late onset growth restriction. When everything is normal and the baby's fetal weight is above the 3rd centile, you would call it as an SGA fetus. Now what about the AGA fetus, the second group, the fetus that is above the 10th centile? Now, if a fetus is above the 10th centile, I mean, most of you must be doing a growth as well as a Doppler scan. There, what you're going to look for is you're going to look for the CPR and drop in growth velocity. So, if there is a drop in growth velocity and the CPR is abnormal, even in fetuses between the 10th and the 50th centile, you're going to be worried and you're going to manage them exactly as you would manage late onset growth restriction. So this was first studied in this paper by Baski's group, where they looked at 11,000 pregnancies and found that when the fetus was between the 10th and the 50th centile, and if the CPR was abnormal, these fetuses had a higher risk of cesarean section, low pH at birth, low FGR scores, and higher NICU admissions. The Fetal Medicine Foundation again looked at this data, and they came to the conclusion that if you really want to pick up those fetuses that are at risk in the AGA group, you have to time your ultrasound as close to term as possible. You can't do a scan at 32 weeks and pick these fetuses. You have to do this ultrasound most likely between 36 and 37 weeks, because that is where these fetuses will show a sign. Why? Because the placental damage is so less, these babies will feel the pinch only when they are closer to term. Whereas at 32 weeks, they will be growing pretty well, because that's the time you usually do a scan. And after that, you will be only clinically assessing these fetuses. You will not do a scan. And then most of the times, these are the fetuses that are going to land up in trouble. So if you have a fetus that is between the 10th and the 50th centile, I would suggest that you do a repeat ultrasound at around 36 and 37 weeks to be sure that you're not looking at an AGA baby that is growth restricted. So there are a lot of confusion as to whether we should do it or not, but the recommendation from the Fetal Medicine Foundation has always been to use it with caution. Do not label these babies as growth restricted and go in for a cesarean section. That's not what I'm saying. What I'm saying is that these fetuses are probably at an increased risk, so they would benefit from the same management that you do for late onset growth restriction. And what is the management in late onset growth restriction? It is not direct cesarean section. It is more frequent surveillance and induction of labor by around 38 weeks. By doing that, you would prevent unwanted stillbirths in that group. So let's put all that together. When you have an FGR fetus, SGA fetuses and SGA fetuses are statistical definitions. They are not the definition that we are looking at. So when they fall into these two statistical criteria, then you divide them based on their abnormalities in Doppler and their estimated fetal weight for the SGA fetus. And for the AGA fetus, you look at growth velocity and Doppler. I hope that's clear. So now we proceed into the management part. That was on how to pick up a small fetus. Now when it comes to management, there are two key concepts that all of us should understand. The first one being cardiovascular adaptation versus brainstem suppression, and the other one being hypoxic threshold versus lung maturity. Now, why is this so important is that because this placenta is a very unique structure. It is the only structure that functions both as a nutritional organ as well as a respiratory organ. It functions to provide nutrients to the fetus. It functions to provide oxygen to the fetus. So it is both the nutritional as well as the respiratory organ. And we use the nutritional part to make the diagnosis. Because when the nutritional part is not working properly, this baby is going to be small. And that's what highlights the problem. So you look at the nutritional capacity of this organ to make the diagnosis of FGR, but you decide to manage them based on the respiratory capacity. So you're looking at smallness to make the diagnosis, but you're looking at the respiratory capacity. You're looking at hypoxia and acidosis to decide whether to deliver or not. And that is the distinction. The smallness criteria is only for diagnosis, whereas for deciding to deliver, we need to look at these two concepts. So what's happening in the fetus? Why is there two different entities like cardiovascular adaptation and brainstem suppression? Now, cardiovascular adaptation basically means in a condition that happens early, for example, in early onset growth restriction, you have a heart that is beating against increased peripheral resistance. So this heart is trying to pump blood against a bad placenta over a long period of time. So what's going to happen? the heart is going to fail. So cardiovascular adaptation only happens in that subgroup where there is early onset growth restriction, where the heart has to work for a longer period of time against resistance. But what about late onset growth restriction? As I told you, the umbilical artery is going to be normal, so there is no increased pressure on the heart. The heart is pumping normally, and so in this subset, you are not going to see cardiovascular adaptation. So why is it important for us clinically? You can't look for the signs of cardiovascular adaptation in late onset FGR. You can't decide to deliver based on the adaptive facility of the heart because it's going to be normal. Whereas in early onset growth restriction, you have to look at the adaptive capacity of the heart to decide on delivery. So what do you do for the late onset group? And that's where you look at the brainstem. The brainstem is immature in the earlier part of the gestation. It is resistant to hypoxia. And therefore, in early onset growth restriction, the brainstem is not going to feel that pinch of decrease in oxygen. But as the gestation progresses, the brain becomes more mature, and even a slight drop in oxygen is going to suppress the brainstem. And once the brainstem is suppressed, what happens? The heart is going to stop. A simple example I'll give you. If a person goes in for a general anesthesia, and if there is hypoxia even for a few seconds, I'm sure you must have experienced that in bad cases of placenta previa and placenta accreta or PPH, where you're very worried about the drop in saturation. So when the saturation drops, even for a few minutes or seconds, you're worried about brain damage. Why? Because the brain is extremely sensitive at that point in adults. And the same thing happens in the fetus. The brainstem, which was completely resistant at around 25 or 26 weeks, at 32 or 36 weeks is highly sensitive. And therefore, when there is a drop in oxygen, it's going to get suppressed and the heart is going to stop. So what happens here is that in early onset growth restriction, we don't have to worry about the brainstem suppression. We look at only cardiovascular adaptation. Whereas in late onset growth restriction, we are not worried about cardiovascular adaptation. We are looking at brainstem suppression. I hope you understand the difference. So what are the tools to assess brainstem suppression? For cardiovascular adaptation, we know we look at Doppler. But what about brainstem suppression? And that's where the biophysical profile and your CTG comes into play. Most of the times, radiologists and people who are doing scans neglect to look at the biophysical profile and also don't advise you to look at the CTG. But in late onset growth restriction, this is your most powerful tool that will help you to decide on delivery, and the other powerful tool is the mother. The mother is aware of the movements of the fetus, and if there is a decrease in fetal movement, especially in a setting of late onset growth restriction, it tells us that we have to be worried about this fetus. The second concept here is hypoxia versus lung maturity. We always get worried about what is the exact time for delivery. How do you actually time delivery? Now here there are two problems. We have to be worried about the fetus dying in utero or coming out and being unable to breathe. So these are the two things that we need to balance. What is more dangerous? Hypoxia leading to intrauterine death, or is it going to be a problem of death in the NICU? As obstetricians, I am an obstetrician who does cesarean sections in and out. What is the easiest way of managing growth restriction? Doing a cesarean section, passing it on to the NICU. I have done it, you have done it, everyone all over the world has done it. Why? Because once the baby is out, then the baby did not die under your watch. And then the NICU does all that and struggles in the NICU, and somehow the baby goes back home. And after that, you don't know what happens to that baby. And many times obstetricians tell me that I don't need this because I can do a cesarean section at 30 weeks. My NICU is good. Yes, your NICU is good and these babies go home alive. But how many of them are going home intact? That is the question. How many of them have problems later on in life? How many of them have learning disabilities? How many of them have early onset disorders in their adult life? We don't know any of these things. And that's why it's important to get your timing right. And that's why I need you to remember this gestational age, 32 weeks. We will deliver fetuses less than 32 weeks only if there is acidosis. Only if you have signs of acidosis, you will deliver less than 32 weeks. And after 32 weeks, you will deliver for signs of hypoxia. Why? The same principle that I told you, brainstem suppression. After 32 weeks, we don't want hypoxia because the brainstem can get suppressed and the baby can die. Before 32 weeks, we are worried about acidosis because this fetus can sustain inside for a longer period of time under hypoxia, and therefore till 32 weeks we are going to look at signs of acidosis, and after 32 weeks we are going to look at signs of hypoxia. So let's look at all the tools that we have. We have Doppler, biophysical profile, CTG, amniotic fluid, I'll tell you why it's not useful, and daily fetal movement count. Let's start off with Doppler. So in Doppler, there are two vessels that we look at, the umbilical artery and the ductus venosus, to pick up both acidosis and hypoxia. Now in the umbilical artery, there are two specific abnormalities that we are looking at. The first one being the absent end diastolic flow, and the next one being the reversed end diastolic flow. Now these two things are telling us two different problems. So the absent end diastolic flow tells us that there is severe hypoxia. The reversed end diastolic flow tells us there is a suspicion of acidosis. So immediately you know something now. What is it that you know? Less than 32 weeks I will deliver if there is reversed end diastolic flow because I am worried about acidosis. After 32 weeks I will deliver for absent end diastolic flow because I am worried about hypoxia. So less than 32 weeks, are you going to deliver for AEDF, absent end diastolic flow? No. So why? Because now we know less than 32 weeks, we are not worried about hypoxia, we are worried about acidosis. And that's why the umbilical artery gives you a clear-cut demarcation as to where you want to deliver this fetus. So if you have absent end diastolic flow at 30 weeks, you will not deliver, you will wait. I know it's extremely difficult when I say this because most of you will say, what if this baby dies tomorrow? It is possible, and that's why I'm going to tell you how we prevent that. We don't just look at Doppler, I'll tell you how we can prevent that, but understand that this Doppler criteria of absent end diastolic flow at 30 weeks is not a criteria for delivery. So let's look at ductus venosus. Now ductus venosus is like the JVP in the fetus. When the heart fails, the JVP rises. I am sure all of you know that. The same thing happens in the fetus. When the heart fails, the precordial vessels will show increased pressure and the DV will show an abnormality. And the abnormality that it is going to show is a reversal in the A wave. A reversal in the A wave. Now why are we worried about the right side of the heart is because the degree of resistance on both sides of the heart is different. The right side of the heart supplies the placenta, and you know in early onset growth restriction, the placenta is bad, and it's the right side of the heart that has to push against that bad placenta. Whereas the left side has an easy job. Why does it have an easy job? Because it is supplying the brain, and the brain vessels are all dilated. So the afterload on the left side is much lesser than the afterload on the right side, and therefore the right side of the heart fails first, and that's why we are looking at the DV in the fetus. Now I'm sure you have heard of two kinds of abnormalities in the DV. The first one being high PI and the second one being reversal. I want you to forget about DVPI. Never think about DVPI and only think about DV reversal. I'll show you why in the cases that I'm going to talk about later. Do not look at DVPI because the DVPI is highly erratic and it is no longer used for your management. So if somebody gives you a report saying that the DVPI is high, you can say, thank you very much, I'll wait, please do a scan again the next day. That's all. You're not going to manage based on high DVPI, and you're going to wait as long as the DV is normal, and once the DV starts to reverse, you're going to deliver. So when are you going to deliver? Any fetus that has DV reversal less than 32 weeks, definitely you're going to deliver. There is no doubt on that, correct? Because we know there is acidosis. And also understand that after 32 weeks, in the late onset group, there's no point looking at the DV because the DV will continue to be normal till the baby dies. Why? Because there is no cardiovascular adaptation. There is no afterload on the heart. So in late onset growth restriction, don't keep on looking at the DV because the DV is going to be normal. Okay? So we understood the umbilical artery and the ductus venosus and where all they can be used. Now comes the role of MCA or CPR. I told you about the effects of hypoxia, that it is going to lead to dilatation in the middle cerebral artery, correct? And we are not worried about hypoxia less than 32 weeks. So in early onset growth restriction, is there a utility for the MCA? There is no utility at all, because we know this baby is hypoxic and we are not going to deliver based on hypoxia, and therefore the middle cerebral artery has no clinical utility in a fetus that is growth restricting early, and there is no point looking at it. Let me give you an example. This is a condition of early onset growth restriction. See how dilated the middle cerebral artery is. But I'm not going to base my delivery based on hypoxia, because I know if this baby comes out now, this baby is not going to survive. I'm only looking at survival and lung maturity at this point of time, and therefore hypoxia is not a criteria for delivery. What about late onset growth restriction? Now here is again an important concept all of you should understand. You will get a lot of reports saying that this baby is having late onset growth restriction, MCA is less than the 5th centile. And some people are so enthusiastic, they will underline it in the report and send it across. MCA less than the 5th centile, please be careful. Now I want you to understand that the MCA is not used in the surveillance of late onset growth restriction. It is not used. I'll tell you why. Because the MCA drops very late. It drops after 36 weeks. And there is no role for it because the level of drop is not very steep. So what is used in surveillance is CPR. You look at the CPR, and then based on the fall of CPR, you're going to increase your surveillance. So the cerebral Dopplers, MCA and CPR are not used in early onset growth restriction, and in late onset growth restriction, you're only going to use CPR and not MCA. Now coming to the last point of biophysical profile, the other tool that we have. Whenever you ask a sonologist or a radiologist to do a biophysical profile, they're always going to tell you it's difficult. I cannot spend 30 minutes looking at breathing movement, fetal tone, fetal movement and all those things. Correct? So the thing you have to tell them is you don't have to look at all these things. All these parameters follows a sequence, which means if the CTG is normal, the whole biophysical profile is normal. Once the hypoxia sets in, the first thing to be abnormal is the CTG. The second thing to go is the breathing movement. So when they are doing a scan, all they need to do is to look at the breathing movement, and if the breathing movement is normal, it immediately tells you that this fetus does not have hypoxia, does not have severe hypoxia. Why? Because hypoxia causes suppression of the brainstem, and in the brainstem we have the respiratory center, the center for movement, the center for tone, the center for cardiac variability. So the most sensitive center is cardiac variability. The next one would be breathing movement. So if those both are okay, it means the rest of the centers down the order, movement and tone, are definitely going to be normal. So all you need to look at is do your CTG and also look at the biophysical profile. So if you have good fetal heart variability and accelerations, you know that the baby is smiling. And to a group of obstetricians, I don't need to tell you anything about CTG. All of you know it and have been using it in and out. So this is your most powerful tool when it comes to late onset growth restriction and AGA fetuses that are restricting pretty late. So let's put all that together. Preterm FGR fetus, there is severe placental disease, the umbilical artery is going to be abnormal, the DV abnormality is what we are looking at, because we know cardiovascular adaptation will set in, the brainstem is resistant to hypoxia, and therefore the CTG abnormality happens very late. So in early onset growth restriction, our markers for delivery are going to be the DV flow and the umbilical artery flow. Whereas in late onset growth restriction, the placental disease is mild and therefore the umbilical artery is going to be normal. There is no cardiovascular adaptation, therefore the DV is going to be normal. The brainstem is sensitive to hypoxia and therefore your CTG is going to be abnormal early. So this is the sequence of events in both early and late onset growth restriction. Now finally, is it important to ask the mother about fetal movements? I know a lot of women do come in and say that there is a problem with fetal movements, and it happens most of the times. And you don't need to be typically worried about it unless in a setting of growth restriction. And here it's important, this paper which came out recently in the AJOG tells us it's not the number of movements, it's the pattern. What is the pattern that she's accustomed to? So if she finds that the pattern is abnormal, and if she says that on 2 different occasions, then that fetus has to be placed under close surveillance. It's not about just one episode. And an interesting fact is 55% of the women that have stillbirth will tell you that there has been a problem with the pattern of fetal movement. So if she comes to you at 2 different occasions, and if the fetus is growth restricted or is between the 10th and the 50th centile, I would be worried and I would put these fetuses under surveillance, not immediate delivery, surveillance, and follow the protocol for timing of delivery in late onset growth restriction. The last point on surveillance, which always creates a problem with obstetricians, is oligohydramnios. I've had to defend this a number of times, and I don't think many are still convinced, but I'll try to make my point here as well. Whenever we have oligohydramnios, especially in a fetus that is growth restricted, as obstetricians we are worried about the baby dying in utero, and that is the reason most of us have this tendency to go in and do a cesarean section. But if you look at this data, it's very clear that the amniotic fluids, when it starts to drop and becomes less, it remains in that same range for a long period of time. For a long period of time. It does not tell us the degree of severity of the disease. It does not tell us whether the baby is hypoxic. It does not tell us whether the baby is acidotic. It gives us no information except that the renal perfusion is less. And therefore, we shouldn't base our delivery on the amniotic fluid. Let me give you a simple example again. 29 weeks pregnancy, small fetus, AFI is 2. You know you are not going to deliver. Everything else is normal, you'll decide to wait. But the same scenario, if it is 33 weeks, AFI 2, all of us are worried. What is the difference between these 2 babies? Both of them have a very less amount of amniotic fluid. What is the difference between these 2 babies? There is no difference. The only difference is our perception. Because we believe that at 32 weeks, this baby will survive in the NICU. Why take the risk? Let me take the baby out. At 29 weeks, we know that this baby might not survive in the NICU, so I will wait. That is the only reason why we make that distinction. But the fact remains that at 32 weeks or 33 weeks, we will not use the amniotic fluid as a criteria for delivery. So to make it clear what things that we use in early and late. In early, we depend upon the CTG and the ductus venosus and the umbilical artery. The CTG functions as a safety net so that you don't miss out on any other problems that can happen in the fetus. Whereas in late onset growth restriction, the only Doppler parameter that you're going to use is CPR and nothing else. Whereas the rest of the parameters are CTG, breathing movement, and daily fetal movement count. So can you see that in late onset growth restriction, the entire management revolves around the obstetrician and not the person who's doing the imaging? Because all the other things are things that you do in your labor room. When the patient comes in, you ask her how her movements are over the past few days. You do a CTG and immediately you know that this fetus can stay in the uterus for some more time. So let's look at this one by one. So early onset growth restriction, I told you look at Doppler and the CTG. Now, what has changed in early onset growth restriction is that we have understood that in early onset growth restriction, we have a sequence of events that are taking place. You have a placental abnormality, you have an abnormality in the umbilical artery, you have progressive cardiovascular adaptation, DV abnormality, and finally fetal demise. So there is a stepwise system happening here. And if there is a sequence in progression, you can classify them into stages and set a protocol. And that's what the Gratakos protocol is all about. They are only dividing early onset growth restriction into different stages and thereby allowing us to decide on our protocol and our management. So based on the kind of abnormality that you get, you can divide early onset growth restriction into 4 different subtypes. The first type would have mild hypoxia because the umbilical artery is still showing forward flow. The second type will have severe hypoxia because the umbilical artery is showing absent end diastolic flow, but the veins are normal. The third type will show reversal of flow within the umbilical artery, but the veins are still normal. And the last type will show a DV reversal. Now immediately you know stage 1 and 2 you can wait till after 32 weeks. Stage 3 and 4 you will want to deliver before 32 weeks, because stage 3 and 4 is hypoxia, stage 1 and 2 is hypoxia, stage 3 and 4 is acidosis. So based on that, you can decide your timing of surveillance and mode of delivery, and also when you want to deliver them. So stage 1 has mild hypoxia, so you can wait till term and you can induce them. Stage 2 has more severe hypoxia, so you can deliver them between 32 and 34 weeks. Stage 3 has a high suspicion of acidosis, and therefore you will deliver them between 30 and 32. And the last group you have to deliver as soon as the DV reverses. Now I'll give you a case example that will tell you how clearly you can decide your mode of delivery based on this protocol. Now these are two women around the same gestational age, diagnosed as having growth restriction. One was told that there is no need to try to salvage the pregnancy, let us wait for intrauterine demise. The other one was told to do an emergency cesarean section. Now these are the growth scans of both these fetuses. Extremely small. You can see that the arrows are pointing less than the 10th centile all throughout. These babies are small. Again, this is the same growth chart. So what do you do next? You look at the umbilical artery, correct? So the umbilical artery is telling you it's an absent end diastolic flow. At 30 weeks, you know you're not worried about absent end diastolic flow. And then you look at the other parameters, the umbilical artery, the MCA and the DV. Can you see that the MCA in both these conditions are below the baseline, telling us that there is hypoxia, but the DV flow is actually different. In Mrs. Y, the DV is above the 95th centile, whereas for Mrs. X, the DV is within the normal range. So whereas Mrs. X is in stage 2, Mrs. Y would be in stage 3 FGR. So immediately it tells you that you would want to deliver the one that is having, or deliver or keep her under surveillance, the one that is having a DV abnormality, whereas the other one you're going to wait for a longer period of time. So that's exactly what we did. And again, you don't go by a single finding. You have to confirm your findings after 12 hours. And for the one that the DVPI was high, after 12 hours, the DV showed reversal. And once it had reversal, we had to give steroids and deliver, whereas the other fetus was put on monitoring. So if you look at just the umbilical artery, you cannot decide your mode of delivery. You have to look at the DV, and if you find that there is a DV abnormality, then you time your delivery based on when the DV reverses. Now there is this question of steroids. Whenever there is FGR, the biggest error that we can make is just give steroids before deciding the timing of delivery. Again, it's a very difficult concept when I tell this to obstetricians, because they say, why not just give steroids and wait? For example, if you have a baby at 30 weeks showing absent end diastolic flow, you will think, let's give prophylactic steroids. Let's give prophylactic steroids and let's wait. Now the problem with steroids is once you give steroids, it can create a change in the Doppler. It can create a pseudo-normalization of the umbilical artery. It can create a change in the CTG. It can create a change in the biophysical profile. The CTG can be non-variable, the fetus can stop moving for some amount of time, the umbilical artery can normalize. And that's why once you give steroids in a setting where you're trying to time the delivery, it becomes extremely difficult after that to manage based on your Doppler findings. So you have to wait till the triggers of delivery are met. And once the trigger of delivery is met, you have to give steroids. I know it's extremely difficult to wait, and once you see DV reversal, to give steroids and wait is even more difficult. But that's how you're going to get your best outcomes. Now coming to late onset growth restriction, as I told you, the most important point, if you want to pick up these fetuses, you have to do an ultrasound as late as possible, at around 36 weeks. Do not stop at an ultrasound at 32 weeks. You have to do an ultrasound again at around 36 weeks, because then you will increase your detection rate. Now this is an example of a fetus that was completely normal at 19 weeks. At 33 weeks, you can still see it is completely normal. Estimated fetal weight is between the 10th and the 50th centile, and this fetus drops at around 37 weeks, falls to less than the 5th centile. So you would have not picked up this fetus unless you did an ultrasound at around 37 weeks. Now remember what I told you, there is no cardiovascular adaptation, so the sequence of events that you saw in early onset growth restriction is not going to happen. You're going to get sudden fetal demise because there is brainstem suppression. Because once there is brainstem suppression, you're going to get hypoxia, and that will lead to fetal demise. So all cases of late onset growth restriction, you're going to deliver at 38 weeks. But what are the triggers for preterm delivery? You're going to put this fetus at surveillance, but what is your trigger for preterm delivery? So you have to remember here, it's not CPR, but the CTG, breathing movement, and the daily fetal movement count that should advise you on what you're going to do with this fetus. Let me show you an example here. 31 weeks growth restriction is there, okay? You can see that the fetus is less than the 10th centile. Now let us look at these Doppler abnormalities a bit closely. On the left side, you can see that the umbilical artery PI is within the normal range, but it is rising, but the middle cerebral artery is dropping. Is that clear? But if you look at, say, around 33 or 34 weeks, the MCI is pretty low, it's around 33, but the CPR is also less at the 2nd centile. So now you're going to get a report that tells you, okay, 34 weeks, estimated fetal weight is less than the 10th centile, CPR is at 2nd centile, and it will be underlined. Would you want to deliver? Will you deliver this baby? What will you do next? CTG? So I did a CTG. Is the CTG good or bad? It's a good CTG, so will you wait? You will wait, right? But because the CPR is low, what will you do? You will increase the surveillance. You will ask for maybe alternate day scanning. You want to be very careful here. Alternate day scanning, alternate day CTG, and you will increase your surveillance. So that's exactly what we did, and now the CPR dropped further. It dropped to around 0.9, but we got some time. Now this fetus is around 36 weeks. Okay, I did the CTG again. Is this good or bad? There is no variability, but still it is not a trigger for delivery. So we decided to repeat the CTG after some time, and this is what we found. What did we see? We saw unprovoked late decelerations, and that's why we decided to deliver. So CPR is not your criteria for delivery. CPR tells you to increase your surveillance. The criteria of delivery is still in your labor room, the CTG machine. That is where you will decide to deliver. Now the next question, late onset growth restriction, should we give steroids? 34 weeks, 35 weeks, should we give steroids for this fetus? We should not give steroids. The idea of giving steroids in that group is only to prevent transient tachypnea of newborn. But if you give steroids, there have been case reports and a lot of postnatal studies which tells us that it is going to affect the myelination of the fetus, and we will not give steroids in late onset growth restriction, and we will only monitor them and deliver them as per the protocol at around 38 weeks. So to put all that together, we should understand the difference between early and late onset growth restriction, and understand that in early, we look at the DV, we look at cardiovascular adaptation, whereas in late, we look at brainstem suppression, and in late, there is no better person to manage that fetus except the obstetrician. Thank you for listening. Should we do the few cases now? Yeah? Okay, the cases I will show, and you can tell me what you think, how to manage. Because that way I'll know whether you really understood what I was talking about. Just 3 cases, not more than that. Nice that whenever you are having a doubt, especially in early onset growth restriction, you're having a doubt on delivery, it's important to, no, I'm good. You have to just follow the protocol. So this is a 28-year-old. She was PIH on Nicardia. She was GDM, hypothyroid. She had all the complications that you could speak of. 23 weeks, we found that this fetus had IUGR. Okay? When you have a fetus that is having IUGR at 23 weeks, immediately you're not thinking about growth restriction as yet, you're thinking about chromosomes, you're thinking about aneuploidy, you're thinking about all those other things, infections and all those things. So we also thought about all those things. Now here one important point I want to tell you is that if you find that the umbilical artery is normal, if you don't find signs of growth restriction, those are the fetuses I would suggest that you go in for high-end testing of aneuploidy, infections and all those things. But if you have a clear-cut sign of uteroplacental insufficiency, especially in this case where you have a mother who is having PIH on nicardia, you're not looking at aneuploidies or infections. And this fetus had an absent end diastolic flow at 23 weeks. And the ductus venosus was found to be normal, and there is no point looking at the MCA because it is going to be compensated. And my question to you is, at 23 weeks, when you find absent end diastolic flow, how are you going to counsel this patient? Are you going to tell her that there is a good chance that this baby may survive? There is a good chance that this mother may develop preeclampsia. This baby might die in utero. What is your counseling going to be? How many of you would want to continue this pregnancy? Showing hands? Good, okay. But all the same, would you counsel the patient telling them that the chances are less? Yes? The chances are less? Okay. That's exactly what we did. We told them that the chances are less because what is the time interval between absent end diastolic flow to DV reversal? It's only 3 weeks. So 23 weeks plus 3 weeks, I'm looking at around 26 weeks. And in 26 weeks, if I do a cesarean section and take this baby out, this baby is not going to survive. And even if it survives, it's going to have long-term complications. So this is exactly what we counsel. Now about surveillance. Here you're not going to do fortnightly surveillance. 23 weeks, there is no point doing fortnightly surveillance because it is only going to increase the anxiety of the mother and you're not going to do any intervention here. So we called them back on a weekly basis just to make sure that the baby was alive. We had basically no hope that this baby would survive. And fortnightly, we looked at the growth. And we kept a close watch on the mother because we were worried about preeclampsia setting in a setting of PIH. So at 25 weeks, this is what we saw. You can see that there is a good amount of flow there. Still absent, okay. DV, good, bad, still good, okay. 25 weeks, now our hopes are a little bit up. 25 weeks, absent end diastolic flow, DV is good, mother's BP is still on the same level, everything is stabilized. We now still ask her to wait. Surprisingly, she reached 30 weeks. Look at her growth. It's like flattening out completely. At 30 weeks, now what are we worried about? We worried about the heart of this baby, correct? And this is what we saw. The DV is good, okay? The MCA is extremely bad. And to our surprise, this baby again went on till 32 weeks. 32 weeks again, she's still going on. The baby is very small. The DV is normal. The MCA is normal. We did the amniotic fluid assessment, also normal. CTG, excellent. 32 weeks, we're looking at the CT. Baby is like moving all over the place. Now here there was a confusion. Should we deliver as per protocol? As per protocol, 32 weeks absent and diastolic flow, we should take this baby out. Or should we wait? What would you do? Pardon? We didn't wait. As I told in the beginning, when in doubt, follow the protocol. Because once you follow a protocol, there is very less chance that somebody can blame you saying that you did not do the right thing. If you wait in this case, yes, probably this child would have crossed maybe 34 or 35 weeks. But it is a risk you won't want to take because this mother is already PIH on medication. And so we delivered this fetus 960 grams and the baby is doing well. So the idea here is, yes, we were worried about writing off this baby, but whenever you have a doubt, just stick to the protocol. That's what early onset growth restriction and the Barcelona protocol does. It takes away the tension of actually making a decision. If you follow a protocol, it is something that you can always defend, saying that, yes, I followed a protocol, and as per protocol, this is the criteria that I looked at, and this is when I delivered this baby. Okay? The next concept is to understand that the mother is equally important. Okay? So look at this fetus. 12 week scan, she had a high NT and a high uterine artery PI. The NT was above the 95th centile, and you can see here clearly that the uterine artery PI is also high, and also the NT was greater than the 95th centile. Between 19 and 23 weeks, we found that the estimated fetal weight was less than the 10th centile. The interval growth was satisfactory, but the uterine artery was abnormal, whereas all the other Dopplers were normal. So would you classify this as growth restriction? Yes, no, because the uterine artery is abnormal and the baby is less than the 10th centile, and you would classify this as growth restriction, and we put her on growth surveillance. We found that the baby's weight was again flattening out, but baby was still growing. The uterine artery PI was also in the higher range, and we classified it still as fetal growth restriction stage 1 because the umbilical artery was normal, and it was only in the uterine artery that there was a abnormality. So we followed them up on a weekly basis, okay? And in early onset growth restriction, I would suggest that all of you remember the biophysical profile and the CTG because it works as a safety net. When you're deciding to follow the protocol of the Barcelona fetal medicine, you should put in a CTG or a biophysical profile maybe once or twice in a week depending upon the risk of the mother, okay? And also we monitor the mother for any change in her BP. At around 29 weeks, there was absent end diastolic flow within the umbilical artery. These are the images. AC less than the 10th centile, absent end diastolic flow in the umbilical artery. MCA is anyway going to be compensated. We are not going to look at it. The DV flow is normal, and these are the growth charts. You can see the umbilical artery is still within the normal range. There is absent end diastolic flow above the 95th centile. MCA is going to be compensated. The DV is normal. The amniotic fluid is normal. The breathing is normal. So what does this tell you? There is hypoxia, but the baby is doing well. 29 weeks. Should we wait or should we deliver? I just told you in the beginning, my mother, my world. You have to look at the mother, no? This mother had this. 160-100 protein creat ratio over the roof, uric acid 8.8, urine albumin 4+. So here we deliver for the mother, not the fetus. And remember, in early onset growth restriction, 70% of early onset growth restricted fetuses will have mothers with preeclampsia. It's not 20%, it's not 30%, it is 70%. It's that high. So when you have early onset growth restriction, always remember that the mother can throw up some problem unless you look at these things. You have to constantly monitor her BP, look at the protein creat ratio, and see if she's going to develop preeclampsia. So here we delivered based on the mother, and the mother is doing well. The last concept is to connect the dots. Sometimes you get an ultrasound report, and it's not that the ultrasound report is wrong, but the ultrasound report is not connecting the dots. They're just sending you pieces of a jigsaw puzzle, like this one. This patient came in for a second opinion. She was classified as 33 weeks stage 3 FGR and was advised immediate delivery. Stage 3 FGR is what? Reversed end diastolic flow in the umbilical artery or a DVPI greater than the 95th centile. Those are the two criteria that were used in the Barcelona protocol. And this was their report, the ultrasound report from outside. Estimated fetal weight less than the 10th centile, umbilical artery normal, MCA normal, CPR normal, AFI normal, DVPI greater than the 95th centile. Something is odd here. Can you get a DVPI abnormal in late onset growth restriction at 33 weeks? Not likely. There is no cardiovascular adaptation. So this was not sitting well. And this was the reason why it was classified as low suspicion of acidosis. So we did the scan. The scan was correct. The estimated fetal weight was less than the 10th centile. The baby was small. Okay. We looked at the DV, and this is what we saw. The DV was showing areas of high PI, areas of good flow. It was all over the place. The DV was actually showing high PI in certain segments, certain periods, whereas it was showing normal flow in certain segments. So what's happening here? The DV cannot be abnormal, that much we know. So why is this DV showing different resistance in different parts. There is no structural abnormality. There is nothing wrong with this fetus. Everything is normal, but the DV is showing different resistance. Why is that? Because the baby was doing this. The baby was breathing. When the baby breathes, the DV will get constricted and therefore the pressures are going to rise. So this baby is not having acidosis, not having hypoxia. This baby is having nothing. This baby is extremely good. Estimated fetal weight less than the 10th centile. All Dopplers normal. Biophysical profile normal. You're probably looking at a SGA fetus. We did weekly Dopplers. We did her biophysical profile and delivered her at 38 and 39 weeks. Now this was a patient who came in for an emergency section at 33 weeks. And when I told them to continue the pregnancy, you can imagine the fear in the mother's eyes. I'm telling the mother that you don't have to worry, go back and come back after a week. She came running in to do a cesarean section, thinking that her baby is going to die now. You can imagine how difficult it is. We sent her back, and next week when she came back, she thought the baby is gone. This doctor is telling some nonsense. The baby was still alive. And so each week, the amount of trauma that she had, it is not a question of trusting us or not, because she does not know who is right. She does not know whether the initial doctor is right or the second person is right. And so we went through that whole trauma and finally delivered at 38 weeks. A small baby, yes, but a small and intact baby. So it's all about choices. You are free to choose any form of protocol, any form of management in growth restriction, but always remember that choices come with consequences, and sometimes those consequences are not so great. Thank you for listening.
Thank you, sir. Any questions from audience?
Hello. Sir, I wanted to ask that you said, how do steroids cause pseudo-normalization of Doppler? I mean, what is the mechanism?
Yes. What steroid is an ionotropic drug, so it increases the cardiac output. Just like when you give dopamine. What happens in cardiac failure patients? We give dopamine to increase the ventricular output, correct? Steroids function in exactly the same way. So in IUGR, the peripheral resistance is high and the heart is trying to pump against that peripheral resistance, and that's why we get absent end diastolic flow. But when we give steroids, the heart's muscular power increases and it is able to push more, and therefore it is able to overcome the resistance. But that is short-lived till the steroid effect lasts, and after that it is going to deteriorate. So when we give steroids, we can find sometimes an absent end diastolic flow becoming diastolic flow, the diastolic flow appearing, or reversed end diastolic flow can become absent end diastolic flow. It is the ionotropic effect of steroids which creates that. Now, another important point is when we give steroids, if we do not see this change, if you do not see the pseudo-normalization, it means that the heart is so bad that even the ionotropic effect is not acting on the heart. Like it's example, the dopamine is not working on a failing heart, which means the heart is really bad. So what does dopamine do? It's the same thing steroid is doing to the fetus. It's clear?
So, but for how long do we expect to see this effect of steroids?
Around 7 days. It's the maximum at around 48 hours, but it can last for 7 days. But the problem here is that we give steroids and we want to deliver, and the next day you do a scan and you find that there is diastolic flow. And then you're confused. Should we deliver? Should we wait? You're not sure what to do. So unless the triggers for delivery are hit, do not give steroids.
Excuse me, sir. So
Yes.
you showed us a case where at 12 weeks there was NT was increased and the umbilical artery was showing high resistance flow in a ICSI patient.
Yeah.
So we start usually patients on 150 ecosprin at night, and 19 weeks the same patient had uterine arteries which were showing high resistance. So in such cases, as a practicing obstetrician, do you start them on low molecular weight heparin?
No. Low molecular weight heparin actually is not used as a preventive strategy in preeclampsia. Only aspirin is, and that also 150 milligrams at bedtime. Heparin we usually reserve only for those conditions that are APLA positive or any thrombophilia cases. We do not give heparin based on the uterine artery PI. No.
Any role of sildenafil?
No, not at all. I forgot the name of the study. There is a study which proved that Viagra is actually more dangerous rather than helpful. It was an Australian study. I can't remember the name, but yeah.
So even at 19 weeks, we just continue with the
Yes.
ecosprin which we were giving?
Yes.
Nothing else in addition to that?
No. I think it's a Strider study. Strider. Yeah, I think it is Strider. I don't remember the name of the study.
Any more questions from audience?
So thank you, sir. Thank
you.
you for the
Thank you.
wonderful talk. You told us in depth about the diagnosis, the management of early and late onset FGRs, the role of Dopplers, when to use it, how to use it, and the role of steroids. So as at the beginning, at the outset, Gandhi sir told us what fetal medicine is. Fetal medicine, basically we are dealing with the smallest patient in the world. And today Bijoy sir has told us and taught us how to manage even the smaller ones amongst that smallest patient in the world. So thank you, sir. I'm hopeful that this lecture will help us manage our IUGR patients better.
Thank you, sir. Thank you, Dr. Bijoy Balkrishnan, sir, for the wonderful talk. I request Dr. Anjali Jamma, ma'am, to felicitate Bijoy, sir. I request our chairperson, please come on the stage. Dr. Anjali Jamma, ma'am, please share her address.
Guests, teachers, seniors, and my dear friends, warm welcome for the very first event of our tenure. We decided to go ahead with much speculation for obvious reason of the Ambedkar Jayanti procession. I am more than thankful to all of you for making it to the venue in spite of hurdles outside. This shows thirst for more knowledge in our members. Gone are the days when fetal growth retardation, oligohydramnios, sudden IUDs were acceptable in registered patients. Nowadays, in modern obstetrics, with a Brahmastra of USG and Doppler in our hands, it is no less than crime to miss those unforeseen mishaps. But this will only be possible if we could use this probe in our hands with utmost efficiency and be able to interpret Doppler efficaciously. Today, my friends, we are here for very same reason. So a very warm welcome to all my seniors, colleagues, members of other societies, our experts, Dr. Ajit Gandhi sir, Dr. Sumit, and last but not least, our esteemed speakers, Dr. Bijoy Balkrishnan and Dr. Pooja Loda, who have traveled all the way from Cochin and Pune, and who will take us forward in the journey of FGR and Doppler. I'm really grateful for being with us today. Thank you.
Thank you, ma'am, and by lamp lightning, to pay tribute to Goddess Saraswati. I request Jamma ma'am, office bearer, the speakers of today's CME, Dr. Bijoy sir, Dr. Pooja ma'am, and our chairperson to please come ahead for lamp lightning ceremony. Gandhi sir, Sumit sir, please come ahead. Lamp lightning. Pooja ma'am, yeah.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्यो
Okay, so Dr. Pooja Lodha needs no introduction. At least in Pune, Solapur, Maharashtra, we all know Dr. Pooja Lodha very well. She is the fetal medicine consultant at Pune. She is the lead consultant at Ruby Hall Clinic. She has her own center, Kangaroo Cradle at Pune. And she is the university recognized trainer and the thesis guide for 1-year fellowship. They have a fellowship in fetal medicine at Bharati Vidyapeeth. So madam is the university recognized trainer and the thesis guide. And she is the conference director for Fitopanishad in the recently conducted 2021 International Fetal Conference, which was held at Pune. Dr. Pooja was the conference director. Besides this, she is the SOGS Young Gynecologist Award winner in the year 2019.
Thank you, sir.
Bas. Okay, so over to you, Dr. Pooja.
Dr. Anjali ma'am, respected chairpersons, Dr. Gandhi sir, all seniors in the audience and dear friends. Special thanks to Monica who managed to get me here today. We have a POGS installation going on yesterday and today. So it's great to be here and really a lot is going on outside, but so happy to see you all. And Bijoy has laid a very good foundation about fetal growth restriction. And I think we are going from 10th board exams now back to the basics primary school, but Dopplers and FGR is a topic, how much ever we do is not enough, and we need to keep going over it again and again for two reasons. One is it is evolving. There are a lot of new concepts. What we thought 10 years back has completely changed now. And secondly, because it's very volatile. So what I actually read about it 5 years back is something I need to really brush up again and again to, add new things today and speak about it. Or is it okay?
Yes, I will.
So yes, Dopplers do add colors to our life, otherwise it would really have been black and white. And just at the outset, I'd like to take this opportunity to kind of seek your support for Tandulwarkar madam, who's standing for the Foxy elections in the coming year. And all these years, the baby has been just a part of the mother. And whenever the mother would come for a visit, blood pressure low, weight low, pulse dekho, stethos se FHH suno, and the baby was just a part of the mother, nothing separate as such. And now what has actually happened?
there's your beautiful baby. Any day now. Really?
You're eating Doritos? He's eating Doritos on my ultrasound. Do you see what I have to do?
I know.
Give me that.
So that's how the fetuses make us dance, and like Sumit said, they are the smallest patients, but that's what they can make us do, and they make us run around every day. So the aim of the talk today is an obstetrician's guide to performance and interpretation of obstetric Dopplers. And if you don't do your own scans, let's see what to expect from somebody who's scanning from you. Because at the end of this talk today, even if you don't scan on your own, we wish that you look at the images, you look at the Doppler patterns, and at least grossly interpret what the baby is trying to tell us. So we'll take you through fetal growth restriction, modes of surveillance in fetal growth restriction, and why Doppler has an edge over the other screening tools. What are the sequential changes? What is a multi-vessel Doppler study? And fetal Doppler in fetal growth restriction, the technique, interpretation, and the decision making. The references for today's talk are, of course, the ISWOG, the international organization which gives us guidelines as to what we do. The Fetal Medicine Foundation, Professor Behshad. Bijoy spoke about the Graticos score, and in Spain, Professor Graticos has done a lot of work on fetal growth restriction, and there is a free online calculator. I don't know if Bijoy mentioned in the beginning of the talk because I came 10 minutes late, but there is a free online calculator where you can put in all the values: gestational age, estimated fetal weight, PI of umbilical, PI of MCA, AFI. These things you put in and it gives you what to do next. So whatever me and Bijoy are talking, you can see free of cost in 10 seconds if you use that calculator, but how to interpret that is what we are going to try to do. Of course, patients are our biggest references and teachers. Whatever protocols we follow, any patient would come up with a surprise. We saw the 23-weeker that Bijoy told us carried on from less than 10 centile till 36 weeks and is alive and well. Obstetric ultrasound has now turned into ultrasonic obstetrics. There is nothing known as a separate obstetrician, a radiologist, a fetal medicine. It's an overlap of a lot of things, and together we are all sono-obstetricians, and we work for the good of the mother and the baby both. Now imagine a situation at 35 weeks that a lady comes with decreased fetal moments, and at 2 a.m., this is how the radiologist resident on call is going to look. Because decreased fetal movements means the Dopplers have to be done. When there are Dopplers involved, there are going to be PI and RI and so many more indices, so many more numbers. The radiologist will have to tell the obstetrician what to do, and so much of confusion. And all this at night. And that's what the obstetrician does. You tell me what the Doppler says and I'll do what you say. So the obstetrician is a happy person right now. Now the radiologist is not behind. He says, okay, you've sent me 2 a.m. decreased fetal movements. Here is the report I give you. Umbilical artery PI 1.4 S/D ratio, RI, MCA, PI. एक बड़ा chart होता है जिसमें 12 numbers लिखे होते हैं, and that is handed over to the obstetric resident. And now that's how they look. So the scenes have reversed. Now the obstetric resident does not know how to read those numbers. Radiologist ने तो अपना काम कर दिया, machine पे जो numbers थे table में लिखकर दे दिया. Now, this is the situation that happens. So, we all together need to understand the meaning of these numbers and why we are working towards it. Like Anjali ma'am said in her address, no more can we accept demises, no more can we accept FGRs dying in utero. So there was an era where there were increased incidence of stillbirths and intrauterine demises. Then came a phase when there was good NICU services but prolonged NICU care. So on the basis that there is a very good NICU, obstetricians started delivering very early. But then the morbidity of the NICU increased. So the fetuses survived, but with a lot of morbidities because we didn't know when to deliver. Baby chota hai, deliver kar do, NICU acha hai, it will take care of it. You cut the cord, baby cries, obstetrician's role is over, neonatologist role starts. That's what was the attitude that time. And then came the Doppler surveillance that made all the difference because we don't need to deliver all the small babies. we can wait in more than 90% of those small babies who have a normal Doppler, and therefore reducing not just the mortality but also the long-term morbidity in these babies. So, carry home healthy baby rate is what defines your success of managing a fetal growth restriction rather than just a live baby at birth. Okay, so intact survival. After 5 years, that baby who was FGR in utero, whom you managed, whom you scanned and delivered on time, is now walking into your cabin neurologically intact, doing well in school, and that is your success story of a fetal growth restriction and not just a baby cry after the cesarean. From the terms of intrauterine growth retardation to restriction, we have now come to fetal growth restriction as an accepted international nomenclature everywhere. It is good to use the same terms everywhere because then we can seek to those guidelines, even legally seek help later if a chance arises. India, unfortunately, does not have guidelines. What actually happened was when the term retardation was used, it was connected somehow to the mental retardation, and therefore that was kind of demeaning or a stigma. So we moved on to restriction, and later we realized it's not intrauterine, the fetus has a special place, and therefore it's now called fetal growth restriction. There's no treatment for fetal growth restriction, there is no cure for fetal growth restriction, and there are only minimalistic preventive measures like aspirin 150 that we discussed. Therefore, close surveillance and delivery decision making are the two factors that will decide the whole success. Now, this is a balance that is constantly needed to be made between the mother and the baby, between the gestational age that you are delivering and the problems that the baby is having. And this slide we will come back to at the end of the talk, and we will realize how every factor there is responsible for the outcome of the baby, and not just the Doppler, not just the gestational age, and not just the weight of the baby. Just in one slide, the difference between a healthy, small, constitutionally small baby versus a fetal growth restriction. You know that the abdominal circumference here is rising on the same line. There is excellent interval growth. It is parallel to this line, and therefore the interval growth is normal. What could this be? SGA, really? What else could it be? Could it be a delayed conception that has not been dated? So start with the basics. Maybe there was already a 2 weeks gap. Maybe at 9 weeks scan the baby was only 7 weeks. And that's the time the dates have not been changed. And therefore, every time we are finding that the interval growth is normal, but the overall weight of the baby is below the 5th centile. Okay, so we don't even need to label this baby as SGA. It's a normal baby which was not dated correctly at 12 weeks. That brings us to dating, because unless we date correctly, we will not diagnose FGR. The best time to date a pregnancy is by a crown rump length at 12 weeks. Too early to date at 6 to 8 weeks, that's not the dating scan. All of you who scan know that 7 weeks pay. When you measure the crown rump length, you are doing it blindly. In a 5 millimeter baby, you don't know where is the crown and where is the rump. So it's just something that you are measuring, and that something could make a difference of huge weeks later. Therefore, according to ISWOG guidelines, the best time to date the pregnancy is between 10 and 14 weeks of pregnancy. But since we don't scan at 10 and 14, we scan at the NT scan. Please use that as the dating tool if there is a gap of more than 1 week between the size of the fetus and the LMP. Don't keep dating everyone, okay? So only if there is more than 1 week gap between the size by LMP and the size on scan, then date the pregnancy at 12 weeks and never date her again. Once you assign an EDD at 12 weeks, that is a fixed point, the target along which we are gauging the growth. If we keep changing our EDD on every scan, आज के स्कैन पे EDD क्या ये है, कल के स्कैन पे क्या है, अगर EDD चेंज हो रहा है तो बेबी हर बार नॉर्मली दिखेगा. We will never be able to pick up an overgrowth or an undergrowth of the fetus if we keep changing our targets. So once an EDD is set, it doesn't change, and that's when all this plotting helps. On the other hand, if you see how this abdominal circumference is starting on the 25th centile, which is very normal, Next scan, it dips down and then further down and then further down, and that's what it's crossing the lines. It's not maintaining the interval growth, and this is something that is not physiological. This is not a delayed conception. This is not an undated pregnancy. This is not an SGA. This is not a constitutionally small baby. This is a pathologically small baby which needs further surveillance. So this is the growth chart that I was talking about. Please go on to barcelonafetalmedicine.com, and it's a very good website for fetal growth restriction decision making. Okay, how do you approach a fetus that is small? It is not just about Dopplers, it's not just IUGR or uteroplacental insufficiency. The first thing you do is look at the anatomy. This especially holds true for early kind of fetal growth restriction, where you're finding that at 20-22 weeks, the baby is already growing small, presuming the dating has been done well. Now, once the anatomy is normal, you assess the amniotic fluid. Yes, Bijoy told us that amniotic fluid is not very important for decision making, but in the early FGR, I'll just tell you at the end of this slide how amniotic fluid can help us distinguish between various etiopathologies of a small baby. So, if the anatomy is abnormal or if the amniotic fluid is increased in a small baby, you are looking at something really, really bad and not just a fetal growth restriction. A fetal growth restricted baby will have a reduced amniotic fluid and a normal anatomy, whereas fetal infections is one such very typical situation where you will find a baby is small but there is polyhydramnios. So, this is a typical setting where you are going to look harder for signs of infection, and that's how amniotic fluid is going to help us distinguish where this small baby is going to lead us. Now, suppose both these factors are normal, then we come to the typical fetal growth restriction with uteroplacental insufficiency, and we find that the Dopplers are abnormal, and we call this a uteroplacental insufficiency, and FGR due to uteroplacental insufficiency. If everything else is fine and there is interval growth is maintained after 2 weeks, this is a healthy, small for gestational age or a constitutionally small baby. So the moment you are labeling that the baby is constitutionally small, it is a diagnosis of exclusion. You've ruled out all of this, and only then you are able to reach to that conclusion that this baby is actually a healthy small baby, which is a very common scenario in our Indian mothers who could be short, who could be a low BMI, and you have to look at all those characteristics as well. Till date, fetal growth restriction was defined only on the basis of fetal weight, but now we have added on Doppler to the definition, and this is extremely important because once the fetal weight is less than 10 centile, you don't jump and call it abnormal. You do the Doppler. If it is abnormal, you call it FGR. If it is normal, you call it a constitutionally small baby. Okay? This is a definition by Gratakos again. If you have a fetal growth restriction, a small fetus and an abnormal umbilical artery Doppler, we used to call it a pathological fetal growth restriction. What has changed? It's not just the umbilical artery that's important, but also the uterine artery and the CPR ratio. We've heard about CPR from Bijoy. We are going to learn about it again. But a small baby along with any of these, not all of these. So either a small baby with abnormal or low CPR, CPR is a cerebroplacental ratio. So a small baby plus a reduced cerebroplacental ratio, a small baby plus high uterine artery PI index, and a small baby which is so small that it's not just less than 10 centile, but less than the 3rd centile is what we are defining as pathological FGR. So these are the criteria, and which is why uterine artery has to be measured on every scan after 12 weeks. It's not just at 12 weeks and 20 weeks that you measure it, and if it's normal you reassure, and if it's abnormal you start aspirin and finish it off. No. It also plays a decision making in defining FGR in the 3rd trimester. This is a new concept. So if umbilical artery is normal, if CPR is normal, if ductus venosus is normal, everything is fine, but the baby is growing very small with a very very high uterine artery PI, you will remember you will not let her continue beyond 37 weeks because she will land up in a sudden fetal demise. So this definition is extremely important. Now coming to the basics of actually performing a Doppler, most of the obstetricians do have an ultrasound machine, and at least viability, growth and Dopplers is something that we all should attempt to do because it is not a rocket science. Performing the ultrasound is not rocket science. Interpreting it is what will need time and time and again trying to interpret the images and translate it into clinical decision making. So first thing is, do not keep a very big area of interest, zoom it to a small place. Then you apply color Doppler, because we all know the ELARA principle of color Doppler. You should not expose the fetus to a lot of radiation, and you should use it in the minimum possible area. So this was a bigger field of interest. If you zoom it, this is what we see. We see the umbilical cord loop. You put in color here, and then you place the pulsed wave gate. Nowadays, we don't need to do any settings. All the machines come with excellent presets. You need to spend a lot of time with the application specialist. Usually when we buy a new machine, we are so excited to start using it that we don't want to give enough time with the application specialist to make the settings. But that's the most important part, because the initial excitement is going to go away in a month or so, and then you will realize, "Arey, color spill ho raha hai, ye nahi ho raha hai," and the application specialist is not going to come back. Keep the specialist with you for 2 months. Let her come every week, because as and when you scan every day, you will realize, "Ha, mujhe ye change chahiye," and when she comes, make her do all of that. Okay, so settings is one of the most important things in the machine, and you don't need to keep playing with the buttons for every patient. There are very good presets for OBs, for low BMI, for twins, for Doppler, for gestation. There are presets. You just need to click, but that whatever the click is giving you to your eyes has to be comfortable, and for that you have to work with your application specialist in the initial days of when you buy the machine. Now coming to the main thing, Bijoy to bol ke nikal gaya, high DV, low DV. Now that's why all the problem comes in, and he requested me to take this part of it, where we have to interpret which one to use. Is it the pulsatility index? It is the impedance? It is the resistance index, the SD ratio, the resistance? We all use all these terms in the reports. We report it, we read it, and we understand it. Can somebody tell me what is the most important, or what are the 2 most important of all these, or all of these? PI. Anything else? What is it that SD ratio will tell me that PI won't? Nothing. Just because I asked a second one, there is no answer. There's just one number you need to know, and that is the PI, and there is no other number you need to know. So stop reporting it. Call up your radiologist if you're not doing your own scans. Tell them to stop giving that dabba of 12 numbers. Tell them to give you only PI and PSV. I'll tell you why you need the PSV. It's the peak systolic velocity. You need it in terms of anemia. That's still a lesser used term, but PI is something that is important and nothing else is important. Okay, and why is that so? All of those who said S/D ratio, in case there is absent end diastolic flow, what is the use of S/D ratio? You don't have a denominator, right? So it's not helping us in any way. All the classifications that we heard, stage 1, 2, 3, 4, do not go on numbers. They go on the waveforms. They have simplified it for us. Reduced end diastolic flow, absent end diastolic flow, reversed end diastolic flow, and pulsatile. So there is no number mentioned anywhere. Only use PI, whatever the gestation and whatever the vessel. So PI does not approach infinity even when there is absent or reversed end diastolic flow, unlike S/D ratio. So in S/D ratio, systolic upon diastolic, if we say there is an absent end diastolic flow, and if our denominator is 0, our values will reach infinity and it will not be helpful for any decision making. So coming to this, what does the umbilical artery tell us about? If an umbilical artery is normal, if the umbilical artery PI is normal, it tells us that the dash is normal. What is normal? Chairpersons are not allowed to answer. What is, if the umbilical artery PI is normal, what is normal? Fetal heart, Placenta, maternal condition, or uterine artery PI? Placenta. In the fetal circulation, okay, what is leaving the placenta? What is this vessel going here? Umbilical vein, okay, that carries good blood from the mother to the baby. And what are these two coming back? Umbilical arteries. Now, if the umbilical artery is showing anything pathological, it means that there is a kind of resistance that is being given from the place where the umbilical artery are supposed to reach, okay, and which is why we see the variations in umbilical artery. Umbilical artery does not tell us about the baby, it tells us about the condition of the placenta, okay. So what are these vessels going to tell us? Uterine artery, of course, we all know it is the maternal Doppler. It tells us about the trophoblastic invasion of the maternal spiral arteries. A maximum vessel distension increases flow to the uterus, and therefore, if the blood flow is reduced, means the pulsatility index is very high. When the resistance is very high, if you are gardening, plants in a garden through a pipe, and if you press too hard and if you don't let it distend, how much pressure is going to require for the water to go ahead? That's exactly what the uterine artery resistance or the pulsatility index means. What does the umbilical artery mean? You all told me very correctly. It tells us about the placental end and not the fetal end. Now, what are the Dopplers that help us know about the fetal health? There are two Dopplers. One is the middle cerebral artery and another is the ductus venosus. Now, let us see how to use those in finding out how the placenta is and how the mother is. So, yes, uteroplacental circulation, uterine and umbilical, middle cerebral artery tells us about the fetal arterial circulation, which means it is telling us how well the baby is adapting to the changes that are happening, in very simplistic words. Okay, so that's what the fetal arterial circulation is telling us, and this is helpful in decision making before 32 weeks, and after 32 weeks it's going to be a pre-terminal stage. So after 32 weeks we do not wait for the DV to go wrong before taking a decision, in short. Okay, we'll come to all that. Starting with uterine artery, I think as a rule now everybody is reporting uterine artery PI at 12 weeks. How is it here in Solapur? Yeah. Okay, so Sumit does it, I know, but everybody else is reporting uterine artery PI at 12 weeks. This has to be done. In case it is not mentioned, please call up your radiologist, request the patient to go back and get a PI. This is one of the simplest things. See, in India, when we talk about Down syndrome and genetic syndromes and microdeletions and duplications, it does not interest the masses as much as it does for preeclampsia and fetal growth restriction, because every day in your OPDs, you are seeing so many of such cases. And if the slightest of a simple intervention, like adding on aspirin or increasing the surveillance or measuring the blood pressure more often or requesting the mother not to gain too much weight is going to help her in the 3rd trimester of pregnancy, there is no harm in doing it. Okay? So this is one of the things where you can intervene really early. Initially, the uterine artery PI was done at 22-23 weeks to predict preeclampsia. It is still better than 12 weeks to predict, but what do we do at 22 weeks? At 22 weeks, if we find that the uterine artery PI is high, all we can do is get scared ourselves and scare away the mother, nothing else. Because then you have lost the window of opportunity to give her something to improve the placentation. And which is why, although not as sensitive as 23 weeks, 12 weeks you need to do a uterine artery Doppler, because if you add on aspirin, 150 milligrams at bedtime, there is no two thoughts about it. Indian population hai, choti mother hai, kam weight hai, 75 grams, no. 150 grams, 150 milligrams aspirin, bedtime, from 12 weeks till 34 weeks, will improve both the waves of placentation. One is between 9 to 12 weeks, so if you start it early enough, even the end of the first wave of placentation you would cover. And the second wave, which is between 16 to 18 weeks, you are definitely covering. Okay? Which you would have missed if you would have done the uterine artery only at 23 weeks. Another thing that was asked after the previous talk is that uterine artery was very high at 12 weeks. We gave aspirin, but it was still high at 23 weeks. In more than 50% of cases, this is going to be the scenario. Do not get disheartened. हमने इतना एस्पिरिन दिया, हमने इतना काउंसिल किया, इतना सब ध्यान रखा, तो भी यूट्राइन आर्टरी पीआई नहीं सुधरा. Aspirin is not to improve the uterine artery PI. Aspirin is to prevent the mother and the fetus from the bad effects of the high uterine artery PI. Okay? So if you are able to reduce the risks of fetal growth restriction, if you are able to reduce the risk of preeclampsia, even if you are able to defer it by some gestations, जो 26 weeks पे होने वाला था, अगर वो 32 पे हुआ, that's also helpful. You don't need to go in and see, अरे PI तो कम ही नहीं हो रहा है. That's totally fine, नहीं कम हो रहा है तो, okay? And that's how you need to, a lot of patients ask us, आप हमको दवाई लेने बोल रहे हो, उसका असर तो नहीं हो रहा है. असर ये हो रहा है कि बेबी अच्छे से ग्रो कर रहा है, आपका BP अभी भी ठीक है. So that's how you kind of need to motivate them to continue taking the aspirin and do not stop it. Now these are technical aspects. You record the uterine artery Doppler pulsatility index. There is a setting. First trimester Doppler setting will help us in uterine artery, and which is the other Doppler we take at 12 weeks? DV. So we will do a ductus venosus at 12 weeks, and you will get very good settings for both of them there. These are the specifications. All of you who are scanning, please, we encourage you to go to the Fetal Medicine Foundation London website and get yourself certified for all these. It's very simple. You do it every day. Get yourself certified and audited, okay? So this is how a waveform of uterine artery pulsatility index will look. Usually, focus on the cervix. It's not very difficult to find if your settings are good. Go to the cervix, go on paramedian to the right side, you will find the right uterine. On the left, you will find the left uterine. It's no magic. The biggest vessel with the highest pulsatility that you see, you place your pulse wave on that and you get the uterine artery Doppler. You just need to make sure that when you measure a uterine artery pulsatility index, the peak systolic velocity, I had told you there's only another thing you need to remember after PI, which is the PSV. The PSV has to be more than 60, because if you get a waveform like this, but the PSV of 45 or 48, you are probably not sampling the uterine artery, you are sampling the descending cervical, and which will not then give you a correct value. So PSV should reach more than 60 centimeters when you take this waveform. So here you see the PSV is around 90. So this is a good uterine. Okay? When you click on the machine, it will give you all the numbers. वहाँ PSV और PI दो चीज़ों पे ध्यान रखना है. These are technical aspects. Set the sampling gate to 2 millimeters so as to cover the whole vessel. So the distance between the two horizontal bars has to be 2 millimeters. Angle of insonation, आड़ा टेढ़ा पूरा angle घुमा के 60 degrees, we will get all wrong information with that. Maximum angle of insonation required, allowed is 30 degrees. The peak systolic velocity should be more than 60 centimeters. Obtain 3 similar consecutive waveforms and the mean PI is obtained. So the concept of diastolic notch is out of the box, because notch is very subjective. यहाँ आपको ये थोड़ी सी notch दिख रही है पर मुझे नहीं लग रही है. So there's a difference of opinion because it's subjective. Okay? So always the international policy makers like SOGS will tell us simple things. They will not complicate things for us. Okay? If there is a difference of opinion, let's go by numbers. And what numbers do we have to remember? We take a mean uterine artery PI of right and left. This is good to write, that measure it 3 times. It may not be practically possible. Take a good right one, a good left one, and take a mean for both of them. Okay, so initially we started off at, just stopping here, for the cutoff values at, there are many papers and a lot of things, but we follow the Fetal Medicine Foundation, and at 12 weeks, a mean uterine artery PI, which is right plus left upon 2, of more than 2.65 or more than 1.65 in the second trimester. So it is trimester wise. In the first trimester, it is 2.65, and in the second trimester, it is 1.65. These are the cutoffs. If there is a notch, the PI still could be low. If there is no notch, the PI still could be high, and therefore you can refrain from mentioning about the notch at all. Just mention the numbers and give the risk for preeclampsia. So initially we used to measure the uterine artery PI at 20 weeks and predict all of this and do nothing about it. Now we have moved on to 12 weeks. We do it at 12 weeks, and what else can we do? Are we all doing double marker, or are we only doing it for more than 35 years? Everybody is doing double marker? Anybody who thinks that it needs to be done only in the elderly or anything like that? Everybody is doing it? Sorry? All of us. Very nice. So I think 4-5 years back I had come here, and I think only 20-25% would agree that we should do double marker for all, and this is a very welcome change. Again, not going in for Down syndrome, but going in for preeclampsia and FGR. PAPE is such a beautiful tool along with high uterine artery PI to predict your preeclampsia and fetal growth restriction, that you can triage this women, you know. Many of you have got heavy OPDs. You cannot afford to call a lady every week for blood pressure. Why not triage them at 12 weeks as to who is at high risk and who is not at high risk? And what factors are going to give us this high risk group of women is these factors. Is the woman high BMI? Is there a history of previous miscarriage? Has she had a previous baby that was just 1.5 kg at term? Did she have preeclampsia in previous pregnancy? Is she a case of chronic hypertension? Is she advanced maternal age? Is her PAPE mom on double marker less than 0.5 moms? Is her uterine artery PI high? We have a list of, is she IVF conception? Is she twins? These are the factors that we are going to group to tell her that, look, you are really at a high risk. Let's do something about it. So that's why 12 weeks is a very good window of opportunity to triage the women into high and low risk. And of course, it gives us a window of intervention. Now, again, something new, like I told you, it's not just the end of the story, doing a uterine artery at 20 weeks. Tell your radiologist to report the uterine artery even later, especially if it is a I wouldn't call it a late onset IUGR, any kind of FGR. If the baby is growing small, we have to know the status of uterine artery PI, because the risk of fetal demise after 37 weeks in a normal umbilical, a normal DV, a normal fetal MCA is very high if the uterine artery PI is high. And then we add, सब कुछ सही चल रहा था, 2.5 kg का baby है, suddenly there is an IUD and you don't know why. So maybe she went into a late FGR with a high uterine artery PI, and then we have to give, you know, kind of excuses like cord around the neck and all. And we all know, we have done everything. 34 weeks tak sab scan hue, sab sahi chal raha tha, preeclampsia nahi hai, kuch nahi hai. But there are subtle things that could get missed on, but we need to see it to know that it is high. Okay, only then can we deliver at 37 weeks. So, yeah. So all that matters is PI. Now this value of 2.85 was initial. It has now been revised to 2.65 to increase the number of women included in this high risk area. So this was the first spray trial that was done, which came up now with the secondary results. So all this we've discussed. The history is important. The blood pressure is most important. Do not ignore the basics. Whatever we are talking today is over and above the basics. What matters the most is the mother, and then we are coming down to the fetus. And why not care for the both if possible? So maternal characteristics, biophysical markers and biochemical markers. All of this together is going to give us a prediction for fetal growth restriction and preeclampsia and even fetal demise later in pregnancy. So a lot of these women will be RPL, multiple previous miscarriages, early losses, bad obstetric history. And maybe when we check for an immunological profile, we don't always do everything. We just do the 3-4 common tests. Thrombophilia C, protein C deficiency, protein S deficiency, doesn't cover everything. MTHFR gene mutation, it costs so much. You'd rather just supplement folic acid. So many such unknown triggers are there which may not come out in a blood test, but this needs to be very thorough. Through a quick history, we can triage her into a high risk and low risk. And see the importance of this prediction and adding on aspirin. If you predict at 12 weeks that this lady is high risk for preeclampsia or fetal growth restriction, it's not the ones that develop after 37 weeks. We are not worried about 38 weeks PIH. You will deliver them right away and then everybody is happy. But it's the ones that are before 34 weeks that are very worrying, because it's going to add on to the risk of the burden of monitoring, surveillance, when to deliver, prematurity, long-term morbidity, and so much more. And this is the group of women that is predicted by the 12 weeks model, and therefore it is extremely useful. Now coming to the umbilical artery. Okay, so this is a simplified version of how the umbilical artery looks. This is the baby and the placenta. We zoom in the umbilical artery. There are two umbilical arteries. And this is going to the placenta. So it's being pumped out by the heart and going to the placenta. This is a normal umbilical artery waveform with a lot of end diastolic flow. This is all the end diastolic flow. This is a normal umbilical artery. This is the systole and this is the diastole. And that's when we say that the end diastolic flow is normal. This is a good wave because the placenta is very healthy. Now let's see what happens. If a part of the placenta is destroyed due to maternal disease or a placental abnormality, the resistance through the umbilical artery. So the umbilical artery will not be pumping good enough blood into the placenta. And then what happens? See now, it's going with a lot of resistance intermittently. And this is how the waveform looks. Can you see the difference between end diastolic flow between the two waves? It has now reduced. What next? Further damage to the placenta. The blood pressure keeps on increasing. Okay? And now there is no end diastolic flow. This is an absent end diastolic flow. If there is further resistance, you see a reversal in the end diastolic flow, and this is what we know as reversed end diastolic flow. So now do you agree that just looking at the waveform, you can classify into the 4 types of FGR? You don't need to know the numbers, you just need to look at the waveform. And how do we do it? I think it's technically very simple. Search for a free loop and not a crowded loop as was shown before. Here, place your calipers on the umbilical artery and just sample the vessel. Okay, so where to measure it? Neither at the placental end nor at the fetal end. Because the placental end will give us a, what is it going to give us? Lesser resistance, a lesser PI. So we are going to miss out on the, the kind of babies who are going to have a compromised umbilical artery flow later if we sample it very close to the placenta. If we sample it too close to the baby, what's going to happen? Very high PI. Why so? Why is the PI very high near the baby and very close? Very good. The distance, how much more it has to still cover, right? So from the baby, the umbilical cord will now go to the placenta, and if you sample it there, you are presuming that as and when the blood is going to travel, it's going to release some pressure and you are going to miss on all of that. And you will falsely find a very high PI if you sample the umbilical artery closer to the fetus. So as a gist, just remember, you're going to sample it in a free loop, neither near the placenta nor near the baby. Now, from when to measure? Usually fetal Dopplers should be done after 26 weeks unless there is a fetal growth restriction that you see at 23 weeks. So you saw in cases that 23 weeks pe FGR start ho gaya tha, the one that Bijoy shared in the end, and he did an umbilical artery to see that the umbilical artery end diastolic flow was absent. Did we do anything about it? No. Therefore, Doppler is not a decision maker before 26 weeks. It's a pre-viable gestation for us in India, and therefore it is recommended that we do fetal Dopplers after 26 weeks because we don't do something unless it's helping us in decision making. Okay? So he showed us the umbilical artery, but he did not use it to deliver the baby. It was absent. We could have, gotten really tensed about it and deliver. But there was no use delivering so early. If we are any which ways waiting to happen, do not encourage deliveries before 26 to 25 weeks. Okay? Do not give hope to the parents that it's all going to be fine, because again, our first slide, intact survival is important. It's not the life and the death. Okay? Still, if the couple wishes to continue, you need to take a consent like that. And what all do you need to do in delivering a 25-weeker? 700, 800 grams. What will you do? You are delivering her. The parents want the baby to be delivered and do everything for it. What are you going to do? First thing, steroids, 100%. What else? MgSO4. Will you give steroid first or MgSO4 first? Steroid first. And when will you give MgSO4? Yes. So, just a few hours before, you plan to deliver. So that's the difference between giving steroids and giving Maxalf. After giving steroids, you need to wait for the window for it to act, approximately 48 hours. And after giving Maxalf, you need to deliver as soon as possible. Okay, so if you have already planned a cesarean tomorrow morning at 9 o'clock, you can start her on Maxalf from 5 a.m. What else do you have to do? Give steroids, give Maxalf. वो तो first होना चाहिए था, but yes, good NICU. Talk to the NICU council. What else? Connect the dots in Bijoy words. ये चारों को dot connect करो और एक और चीज बोलो. Don't you need to tell your NICU people you're giving Maxalf? Why? Baby is going to be suppressed. Okay? Any which way it's a 700 grammars. It's severe prematurity. They are going to lose hope. उसके ऊपर से वो baby floppy रहा. They will run an errand of, reasons कि क्या हो रहा है. At least if you tell them that there is Maxalf, they will know how to give an antidote and bring up that much of a respiratory depression in the baby. Okay? Keep communicating with your neonatology colleagues. Tell them you have given a steroid, not given a steroid. There should not be a situation when you are not giving steroid in such a thing. I mean, always give steroid. She's come now, you are taking her for a section. तुरंत वहीं दे दो. Whatever little benefit it's going to have in the next 1 hour is a benefit worth taking. Okay? So please do it. Do you measure umbilical artery in everyone? Now this is a topic of debate. 30 weeks, excellent fetal weight. Do you want to do umbilical artery PI? Why? Normally growing baby, there's no other problem. Do you still want to go in and do Dopplers? There is not enough evidence to support that this is going to help, but we all do it, okay? Because it takes 30 seconds and it really reassures us. Once the Dopplers are normal, we are sure that mostly nothing is going to happen for the next 2 weeks, okay? So that's something we do against evidence. In twins, where do you measure the umbilical artery in twins? It's so confusing for all those who scan at 34 weeks. Sab jagah dono babies ke umbilical cord hai. Where do you sample it? Yes, near the cord. And therefore, what happens when you do it near the insertion of the cord? The PI will be high. Therefore, in twins, the umbilical artery chart is different from the singleton chart. Okay, because if you follow the singleton chart, you will find that the PI is very high. We just saw why it's high, right? So, the charts are different. Your software should recognize it's a twin pregnancy and therefore, accordingly, it will adjust it. Single umbilical artery. Something different happens with this. There is no significant difference in an umbilical artery of a single umbilical artery and a normal fetus. What is the effect of steroids? We just heard it from Bijoy. So what is the maximum, if we give steroids today, when do we see a transient improvement in the Dopplers in umbilical? Maximum effect is at 48 hours and it's usually lasts up to 4 to 5 days. Okay? If you want to base your decision making on the basis of Doppler, if you have decided to do a cesarean because of a small baby and impaired Dopplers, you are giving steroids and waiting, and you find कि अरे आज Doppler की आप सुधर गया है, do not leave her home. Because we know this is a transient improvement in the Doppler, but it also tells us something good. What does it tell us? The heart is still responding, right? Because if it does not, if giving betamethasone or dexamethasone is not acting as an inotrope, means the cardiac cells are not responding. It's a worse situation, okay? But if the heart is responding, it's a good thing, but do not leave her home, because in the primary place, you've given her steroids because you want to deliver her, right? So keep her admitted under surveillance and then see what happens after a week, because maybe the Dopplers come back to bad after a week. So this is how it looks with the amount of placental damage. The red part is the placental damage, and this is the corresponding umbilical artery that you get. So half the placenta is damaged if you get an absent end-diastolic flow. 3/4 of the placenta is damaged, you get an reversed end-diastolic flow. There are situations when the baby is breathing, like Bijoy showed you the ductus. Similar things could happen even with the umbilical. When in doubt, wait. Make her go for a walk, eat, rest. You also eat and rest and come back and do the Dopplers again. Okay? Do not jump on conclusions, because one conclusion made by you is going to affect the decision making by the obstetrician. Why is umbilical Doppler why are we so obsessed about it? Because huge studies that umbilical artery Doppler in utero, in small babies, is going to affect the neurodevelopment till adolescence. It's not just the next 3 hours, 3 days or 3 weeks. It's up to 21 years that the studies have done, and there are IQ changes if you just wait. अरे EDD तो 30th January दिया हुआ है, हम थोड़ी 3rd January को नहीं डिलीवर करेंगे, we'll wait till 20th January. See what is happening inside. Is there an advantage of waiting for another 2 weeks? What are you giving the mother? What are you giving the baby by waiting for those 2 weeks? With an excellent NICU setup, do you want to really get that close and deliver just a live but acidotic baby? Or a live but hypoxic baby? Or do you want to safely deliver a mature and neurodevelopmentally normal baby? And that's where the umbilical artery PI is extremely important. Now the $1 million question, what value of umbilical artery PI is normal and what is abnormal? Can somebody help me with this? Above 1 is abnormal, 1.5. PI, we talk about only PI. So what is abnormal? There is no abnormal or normal value of umbilical artery, and that is because it changes with gestational age. So you get calls, umbilical artery PI 1.2 है, deliver करूँ क्या? कब? कौन से बेबी में? वेट कितना है? जेस्टेशनल एज कितना है? AFI कितना है? मदर को PIH है क्या? So many factors go around it. Now if you look at this, the same umbilical artery PI, which is 1.5 at 20 weeks of gestational age, is totally on the 50th centile for gestation, has now come on to 95th centile of gestation at 40 weeks. So can a number give you information? It's like NT, it's like nuchal translucency. Is 2.5 normal? Yes, it's normal for 13 weeks, 6 days. It's not normal for 11 weeks. Similarly, 1.2 is very normal for 28 weeks, but it's not normal for 38 weeks. Don't go by numbers, and that's again where that calculator will help you. You don't need to go to the calculator for every patient, but next time you get an FGR, a small baby, please try to enter all these things. It's a very simple one. You enter all of this and you don't have to put in your brains. It will just give you an answer. No need to deliver, give steroid, follow up Doppler after 3 days, review. Or it will give you give steroids and deliver. Or it will give you deliver immediately. It will give you very clear instructions. Okay? So coming to the next one, middle cerebral artery Doppler. You focus on the circle of Willis and you find that the middle cerebral artery has to be imaged here. This is how it looks. Now very grossly, since I want all of you to read your images even if you don't scan, if this was an umbilical, forget that we are talking about an MCA, okay? If this was an umbilical, was it good or bad? It's good. So do you think there is a lot of end-diastolic flow or a lot of systolic flow? Systolic is very high, right? And what did we see in that umbilical? Diastolic flow was much more than the systolic flow. Got it? In proportion, I mean. All the Dopplers that show less end-diastolic flow means the vessel is giving resistance somewhere for some reason. So a good MCA will look like a bad umbilical. Why so? Because MCAs are naturally supposed to show resistance. What is an MCA? It's telling us about the brain of the baby, how it is adapting, okay? Under normal circumstances, when the baby is well fed, getting good blood supply from the mother, growing well, the middle cerebral artery, वो बहुत ठाट बाट में है, बहुत resistance देती है वो, because उसको वैसे भी oxygen मिल रहा है. Got it? Why is it going to compromise if it's anyways going to get oxygen? And therefore, this is a normal MCA. It's got a lot of resistance because brain and adrenal are the two most important organs in a fetus. If everything goes wrong, these two will get the maximum blood. बाकी जगह से shut down होना शुरू हो जाएगा. And last stage में, decompensatory stage में, when nothing else is working out, then the brain and the adrenals will shoot. Okay? So अभी तो it is बहुत ही ठसन में उसका I'm going to be resistant, you take blood from me. That's what's going on, and that's why the resistance is so high. This is a normal MCA. Okay? Now if you go further, Let us see this. And this you'll realize when you compare this with the umbilical chart that I showed you, okay? So is this a normal MCA? Why so? Yeah, a lot of resistance, right? That's how it's supposed to be. That means the baby is very well fed. Now what has happened to the other one? थोड़ा सा end-diastolic flow increase हो गया है. It started to थोड़ा झुकना शुरू किया है fetus के brain ने अभी कि नहीं अभी कम blood आ रहा है, थोड़ा चौकन्ना हो जाओ. I need to have oxygen now. Let's start some kind of mechanism to take more blood. So it's starting reducing the resistance. PI reduce होगा कि increase होगा? Reduce होगा, right? And therefore low PI is not good. ठीक है? Is low PI is not good in MCA for this same reason. Now look at this third one. If this would have been an umbilical waveform, was it good or bad? Very good. Very good, thank you. So, why was it good? So much of end-diastolic flow. Placenta इतना अच्छा है कि umbilical बहुत fast blood भेज रहा है वहाँ तक. Okay? But ये तो brain है. This is the brain. This is the middle cerebral artery. And look at the diastolic flow, how much it is. Why is it so high? Total vasodilatation. Now the brain has realized all the organs have shut. Okay? So now it has to completely compensate and try its best to extract the most out of the blood reaching it, and therefore it completely reduces the resistance and therefore it reduces the PI. So in a typical case of fetal growth restriction with an abnormal cerebroplacental ratio, by cerebral we mean MCA, by placental we mean umbilical. So क्या होगा? The umbilical PI will be high and the MCA will be low. This is what is CPR. What is cerebroplacental ratio? It is the combination interpretation of the umbilical and the MCA. It's no other rocket science. And this is what the whole pathophysiology is. MCA is extremely important Doppler for decision making in more than 32 weeks. We just saw that less than 32 weeks, MCA does not have any role. Why does MCA does not have a role in 32 weeks? Yes, the baby's brain is not so developed that it knows how to react to hypoxia. It's just like your CTG. Okay, so at 28 weeks, will you go ahead and do a CTG? No, you know the myelination is not complete. The baby may not show, the sufficient changes for us to be reassured on the CTG. Similarly, the MCA, the systemic adaptation has not yet happened that the baby's MCA shows changes. And therefore, it could show haphazard changes. It could suddenly show a very bad MCA or a very good MCA despite the baby being bad, just like it happened in Bijoy's case. Okay, but again, was that a decision maker at 23 weeks? It was not. More than 32 weeks, you use MCA and you don't use MCA alone, but you use along with umbilical, which is known as the cerebroplacental ratio. Okay, so yeah, there is a concept where everything else is going fine, but the MCA PI is low. And that is an isolated fetal cerebral vasodilatation, which should not be continued more than 37 weeks, even in a normal growing fetus. So this is one of the reasons why Dopplers can be done in all, because this is a situation where we could suddenly have a stillbirth, the baby being excellent in weight, no FGR, umbilical fine, ductus fine, uterine fine, mother fine, MCA is low. So there are certain conditions where due to hypoxia, it could be cord compression, it could be other environmental changes near the baby, which is causing intermittent reducing MCA PI, which is cerebral vasodilatation in the baby, causing a sudden IUD after 37 weeks. And therefore do not ignore the reports that say that fetal MCA PI is low. Okay, repeat it. Do not jump to a conclusion at 34 weeks. Get her admitted, give her steroids to be on a safer side, repeat the Doppler in 3 days. If it remains that way, try to deliver her before 37 weeks. So coming to the cerebroplacental ratio, the cerebro means MCA, placental means umbilical artery, and when you take a ratio of both, that's what you get. Increasing umbilical artery PI, just as we plot growths, we plot Dopplers. Trends are important. One day findings are not important. Okay. So we see that this trend has begun from a low umbilical artery PI. Is this good or is this good? This is better? Yeah, umbilical artery PI is supposed to be low, right? So it was normal, then it started growing and further, and it reached beyond 95th centile. So that's a growing trend, you need to be cautious. Simultaneously, what happened? The MCA was reducing. Okay, so beautifully the babies show us this trend. And that is why this is the trend of the CPR. So a cerebroplacental ratio of less than 1, more than 34 weeks, deliver. This is a rule of the thumb. Okay? Less than 1. Less than 1 means umbilical artery PI is very high, MCA is very low, and more than 34 weeks. So maturity is there, which anyways we know we have to deliver this. So CPR less than 1, more than 34 weeks, deliver. Ductus, Bijoy has concentrated a lot on ductus. I will just go through it very quickly. What are the 2 uses of ductus? One is, sorry? Yeah, decision making Doppler in early FGR. So if there is one blood flow that decides delivery at 26 weeks or 27 weeks in a small baby, it is a ductus. It is not the umbilical and it's not the MCA. What is the other use of ductus? Pre-terminal, 36 weeks, wait for acidosis. That's not the use. We never reached that stage. What else? At 12 weeks, why did we do a ductus? Yes, so we predict cardiac abnormalities and it is also an aneuploidy marker. Okay, so these are the 3 uses of ductus in various gestational ages. At 12 weeks when done, it is a predictor. It is a minor marker for chromosomal abnormality, but one of the important markers for evolving cardiac defects. And when done late in pregnancy, as in after 26 weeks, it is a decision-making Doppler for the early fetal growth restriction, yes. Yeah, so we don't reach the pre-terminal. Never, we don't usually see 36 weeks ductus abnormal ho gaya hai. Nowadays, we don't see such babies because we deliver them before that, okay? And we need to deliver them before that. Something very important that as obstetricians we need to realize is, when we have bad Dopplers and we are delivering the baby, make sure that you send the cord blood for ABJ, okay, for blood gases. And why so? Number 1, to prognosticate how the baby is going to do. If there is already acidosis on the blood gas, it will help our neonatology colleagues for the counseling. Secondly, legally, later if something happens, if there is cerebral palsy, if there is mortality, long-term morbidity, and if they come back, your CTG tracings will fade away in 5 years. Your ABG picture and the CTG picture should be stored. That's what the latest they say, because the CTG and the ABG papers are those glossy ones which really go away in 2 or 3 years. They don't remain. And these cases come up when the babies grow up. Okay? So in such doubtful cases, keep a picture, print out and stick. And we really do it. Okay? So especially in the really bad ones, when we know that these are not 900 grammars, 800 grammars, the parents want us, baby is totally acidotic, they've come from an outside referral. We do the blood gases and we stick it there. Because that's help of legal use to declare that while the baby was born, there was already acidosis that had set in. So we are kind of preventing, saving our colleagues, neonatology colleagues, because the parents could argue कि बाद में कुछ गलत किया. So you have to document the blood gases there. Bijoy told us about early FGR and late FGR. I will not go through it again, but we just need to see the main difference between the two. Less than 32 weeks is early FGR, and the main problem is management because prematurity comes in. Okay? And late FGR is after 32 weeks, and why is the problem diagnosis? We don't scan after 32 weeks if everything is fine. Right? And they typically come up with small growing babies after 32 weeks. So the problem there is diagnosis, and the worst problem is you have sudden stillbirths, you have a long term, there is no time for adaptation. You suddenly lose the baby, and that's the whole problem in the late FGR. Now the sequence of changes that happen, first thing that you will get is high uterine artery PI. When will you get that? At 12 weeks itself. Okay? Uske baad, everything is going fine. Then at 28 weeks, in a small baby, you will get increasing umbilical artery PI. then you will get a decreasing middle cerebral artery PI, which means you are getting a decreasing CPR. Then the AFI will start to reduce. Then the lady will come with decreased fetal movements. Then there will be loss of variation and so on and so forth. इसीलिए Bijoy was telling you, do not jump to conclusions and delivery on the basis of only decelerations on CTG or only reduced amniotic fluid index. Okay? Because when the lady is coming with decreased fetal activity, all this has to be abnormal. Only then move less. Okay? So if she is coming with decreased fetal movements, means the Dopplers have already gone bad. But if the lady comes with decreased fetal movements, you do a Doppler and you find everything is good. Please make her eat, rest and concentrate more on the baby movements. Take out a CTG, that is fine. The baby starts moving in 2-3 hours and you are back to square one. You don't need to go and deliver her just because the baby is growing, moving less. Because if the AFI is normal, if the Dopplers are normal, if everything else is fine, there is no reason for the baby to move less because this is a sequence that the baby usually follows. Similarly, everything else is going fine and suddenly on CTG you find that there are late decelerations. How likely is it that all this is impaired and not seen on scan? Not really. Go back and do Doppler. So anytime mother comes with decreased fetal movements, CTG shows changes that are not correlating clinically with your acumen that's going on, please go in and do a simple Doppler and you will get the answer to what is happening inside. Now the only difference in late FGR is it doesn't give you time for adaptation. So it will keep giving you a normal umbilical artery till the end. Okay, and then suddenly there will be a reduced MCA and all those things happening after 32 weeks. So that's very tricky because until 32 weeks everything looks fine and it's after that that the MCA starts reducing, and this is typically what happens in the late FGR, because of which the diagnosis is very different. So on the concluding slides, the principles of monitoring delivery decision making, the monitoring interval, how often to monitor. In early stages, less frequent. We cannot do bi-weekly Dopplers from 26 weeks onwards. We know that if once the umbilical artery end diastolic flow is absent, how many weeks is it going to be like that till the DV is deranged? 3 weeks. We have a lot of time. Then why call her bi-weekly? We can call her weekly. Okay? So, the early stages require less frequent monitoring. And why do late stages require more frequent monitoring? The progression is unpredictable, the progression is faster, you are approaching maturity, if in doubt you can deliver. Which is why your monitoring should become more intense as you near the period of maturity. Okay, which threshold to base your delivery on? Early in pregnancy, keep your threshold very high. Chota sa kuch marker dikh gaya, go and deliver. Not worth it, because the burden of prematurity is so high that you will not be able to justify why you went and delivered this lady. So make sure that you really have all those trigger points ticked off when you deliver a lady before 32 weeks. Okay? Just for absent end diastolic flow in a FGR, are you going to deliver a lady at 28 weeks? You will not, because the DV is normal. Your threshold to deliver early in pregnancy has to be very high. At the same time, if she is 37 weeks, she comes with reduced fetal movements, you find her blood pressure is 140/90, she's got a Doppler which is saying increasing umbilical artery PI. It may not have gone to absent end diastolic PI, and which is why plotting is important. Unless you knew ki pehle ka PI kya tha, you will not know the trend. Got it? So this time these are all borderline findings, but what is her gestational age? It's 36 weeks. Do you want to really keep your threshold very high? Let's wait till 40, let's wait till 38. There is no advantage. And why is there no advantage? Because, on the next slide I'll tell you why there is no advantage. Here, every day that you are keeping the baby in utero, you are reducing the morbidity and mortality by 2%, which is a lot. Okay, so just because 28 weeks absent end diastolic flow, don't go and deliver. Make sure you are really sure about why you want to deliver her, because your intact survival rates increase the more you keep the baby inside. Okay, on the other end of the spectrum, why do you want to deliver most of these babies at 37 weeks? If you see, the risk of stillbirth is way high when the gestational age goes beyond 37 weeks. So till 37 weeks, you are fine trying to pull her on if everything is fine. But after that, the statistical benefit of delivery outweighs the risk of continuing the pregnancy. If you continue from 37 to 39, how much extra maturity are you going to gain versus the risk that you are taking to have an IUD suddenly? Okay, therefore 37 is the time that we decide to deliver them. This has already been covered with Bijoy, so I will not go through it. And I think this is a flow chart of what Bijoy has told and I have told. Once the baby is less than 10th centile or the abdominal circumference is less than 5th centile, serial measurements have to be done to see the baby weight. How often to weigh the baby? Every 3 days? 1 week? 2 weeks. Why 2 weeks? That's a perfect answer. Why 2 weeks? We need to tell this here because we get demands. हर 3 दिन में baby weight के लिए हमारे पास requisition आता है. If we go and stand on the weighing scale every 2 hours, are we going to appreciate our weight difference? उतना तो error ही हो जाएगा हमारा measure करते करते. So no use. And then parent, अरे कल तो 1.8 था, आज 1.7 हो गया, मतलब baby lose कर रहा है weight, let's go and deliver. It's just an error of 15% that you have in baby weight calculation. There should be a gap of at least 2 weeks before you measure the weight of the baby again, okay? So once you have a small baby, you do all the Dopplers. By all, we mean all, including uterine, including MCA, ductus and umbilical. Umbilical artery normal hai, fortnightly interval growth, Doppler, if it's normal, go to 37. If you think she's just small like the mother, wait for spontaneous labor and go until 40 weeks. Do not reduce your surveillance, okay? If you think umbilical artery is more than 95th centile but end diastolic flow is present, do you need to know the numbers for this? You don't. Just look at the graph. Is the end diastolic flow present? Yes, it is present. Weekly, this is wrong. 2 weekly estimated fetal weight. Bi-weekly Dopplers, extremely important bi-weekly Dopplers. Recommend delivery at 37 weeks. We just saw why 37 weeks is important. If the growth is static for 3 weeks, you are plotting it, right? If the growth is static for 3 weeks and the Dopplers are same, go in and deliver. You're not giving any advantage to the baby inside. Okay? Third scenario, there is absent or reduced end diastolic flow. Do daily Dopplers. Try to pull on till 32 at least because this could mean a normal ductus. DB will then decide before 32 weeks. But after 32 weeks, if it continues to be absent or reverse ductus, go in and deliver this baby after steroid and max self. So this sums it all. And we come back to this. So there's no one factor that helps us in decision making. It is everything. You have to weigh the risk of fetal acidosis and fetal demise versus the risk of prematurity. Just because your hospital has an excellent NICU setup, you don't go in and deliver everybody at 32 weeks because we saw till 34 weeks, every day in utero is improving the long-term outcomes of the neurodevelopmental intactness in the baby and try to keep the baby inside as much as possible but safely. You have to play safe between the two ends of the spectrum and not swing on one of them. Thank you so much for a patient hearing. सुमित तुमने किया ना? Nature's way of telling us to stop. Do you all have any patience to listen to oligo in 2-3 minutes or it's fine? It's not much, it's a very quick presentation. Role in decision making. It's actually right because the prognosis of isolated oligohydramnios when everything else is fine is excellent. It's as good as anybody else with a normal AFI. So we've been overrating amniotic fluid for all these years. Doesn't mean we totally neglect it. It is a part of the whole assessment of as a tool for screening of a small baby. But rarely will you find that the weight is fine, the Dopplers are fine, the mother is fine and the AFI is too. Usually doesn't happen that way, okay? So there's no one number of amniotic fluid that's normal. It changes with gestation. But overall, when you measure the amniotic fluid, there are two ways of doing it. Number one is you divide the mother into 4 quadrants, right, left, lower, right and lower left. And you take the deepest pool in each, you add them all up, and this is the total amniotic fluid index that we all know since years. The normal range is between 5 and 25 centimeters, less than 5 is oligo, more than 25 is poly. This is what we have been doing since years. But if we apply this classification and try to deliver babies, because how many of you are comfortable in continuing a 32-weeker who has got an AFI of 3.5 centimeters? Will you continue?
Sure. If everything other things are normal.
3.5 centimeters. Okay, most of the obstetricians will be really scared to continue. Not because they don't care, but because they're really scared of the fetal demise that could suddenly happen, okay? Now, this 3.5 AFI is the total of all the 4 quadrants. When we use the total AFI to decide delivery decision making on the basis of oligohydramnios, we have been unnecessarily delivering babies like these, the one that I just mentioned, because of the scary numbers of being less than 5 centimeters. Therefore, what has now come up over the last 5 years is the concept of a single deepest pocket or a single vertical pool. And what do? We screen the whole abdomen, just eyeball the amniotic fluid. Whichever one pocket you find has got the maximum depth, just measure that. You don't need to do the 4-thing exercise and all that. And when this single vertical deepest pool is less than 2 centimeters, it is oligohydramnios, and when it is more than 8 centimeters, it is polyhydramnios. Now this was extremely helpful in reducing the number of unnecessary preterm births, unnecessary interventions for all those AFIs who appeared apparently reduced as 4 centimeter and 4.5 centimeters, but were actually more than 2 centimeters in the deepest vertical pool. Okay, so this was the only concept that I really wanted to bring about. All the radiologists, fetal medicine specialists and you all who are scanning, I know it's a change. All these years we've been reporting AFI 12 centimeter, 4 centimeter. How I started is, suddenly one fine day I get up and say ki naya guideline aaya kal raat ko, let's do now single deepest vertical pool. Nobody's going to accept it and even I'm not comfortable. I started reporting both. So I started reporting both in normal as well, so that they get tuned to seeing such reports. The AFI measures 14 centimeters, which is normal. The single deepest vertical pool measures 6 centimeters, which is normal. So, kal jaake agar FGR baby aayega, they are tuned to seeing these kind of reports. So now what will the report look like? Although the 4-quadrant AFI measures 4.8 centimeter, the single deepest vertical pool measures 3 centimeters. Therefore, consider expectant management for another week and rescan in 1 week. You see the difference now? पहले अगर 4.5 लिखते तो वो deliver हो जाती. So this is the difference that this will make. In twins again it is the same. Twins में तो 4-quadrant AFI होता ही नहीं है. So twins में you don't even measure 2-quadrant AFI nowadays. You don't measure 4-quadrant AFI. You just mention the deepest vertical pool, and that helps in distinguishing the oligo and poly. So yeah, Cochrane, which usually does not come up with any single, proper decision, came up with this, that measuring a deepest vertical pool is a better choice since the use of 4-quadrant AFI overdiagnoses oligohydramnios and the rate of induction of labor without improvement in peripartum outcomes. Okay, so Cochrane is also supporting us. Now this is oligo at various gestations. Of course, if you find oligo on anomaly scan, you either ask for, okay, let's ask for leaking. वहाँ तो किडनीज लिखा है, बट एक लीकिंग पूछ लो, सिंपल. हम ढूंढते रह जाते हैं कि क्यों ओलिगो हो रहा है, और वो लेडी बाद में बोलती है कि 15 दिन से पानी जा ही रहा है. Simple, start with the basic. Leaking hai kya? History hai kya leaking ki? Okay. Second is, of course, you look for bilateral renal agenesis. So these are two things that you will pick up on hydramnios at 20 weeks. You can't miss it. Then PPROM. So in a case of leaking, not always will the mother tell you that she is leaking. How will you suspect it? The growth is normal, the Dopplers are fine, the kidneys are fine, the mother's blood pressure is fine, everything is okay. The cervix is good. Then why suddenly there is no amniotic fluid? Then you may have to do a PS and the test that you do to find out if there is leaking, which I've forgotten now over 11 years. Then there is the typical FGR. Why will the FGR babies have oligohydramnios? Because it's a small baby, less blood volume, less blood going to the kidney, less urine being produced, baby passing less urine, and oligohydramnios. So it's not rocket science to say that the small baby will have a less fluid. It will. Is it impacting our decision making? It is not. Decision making के chart में कहीं AFI था क्या? कभी भी नहीं. Because it goes hand in hand with a smaller baby. Okay? Why is it important to counsel women? A lot of women, especially the IVF and the IUI ones who conceive, with a lot of difficulty and they have some kind of leaking or oligo due to any reason at 21-22 weeks, and it is very hard to convince them about the poor prognosis. We have to tell them, and actually we have to understand ourselves, the problem is not the anhydramnios, the problem is the pulmonary hypoplasia, which is not going to tell us today on ultrasound, it's going to show up later. The whole development of the lung of the fetus is going on right now, and the most active phase of development of the baby is canalicular phase, which decides the pulmonary hypoplasia, because that decides how the respiratory bronchioles are. And if this is the phase affected, between 16 and 26 weeks, if there is no amniotic fluid for the baby to swallow and the bronchioles to develop, this is going to cause the pulmonary hypoplasia. So we have to be very cautious while counseling 16 to 26 weeks of severe oligo of whatever cause, irrespective of the FGR, because the pulmonary hypoplasia is extremely high in these situations. So that's the most important phase in the development. Something excellent that I found when I was making this talk before is that many a times we find everything else is fine. The weight is good, the Dopplers are fine, mother does not have any problem, but the AFI deepest vertical pool is 3 to 4 and the total AFI is around 7 to 8. We are not very comfortable because we are happy with 13, 14 and 15 centimeters. It really helps if you of course tell them oral hydration improve karo, but in a small period of time tell them to drink more water. So rather than having 3-4 liters in the whole day, within 2 hours tell them to have 2 liters. And that improves the osmotic gradient and it's improving the amniotic fluid around the baby, and there are proven studies, and I personally have got really good results with patients and there's no harm in trying. Anyways, itna pani pila rahe unko kyun na 2 घंटों में ज़्यादा पिलाया जाए. So just try this. Secondly, there is no advantage of giving IV and salines over oral hydration. It doesn't make a faster improvement at all. So oral hydration is good enough. Oligo आया तो सीधा admit करके Hermin, saline, it's good for, there's no harm, but it's not doing any good either. So good, oral hydration has to be maintained really well. Amnio infusion, a lot of obstetricians still demand amnio infusion. It has no role, it has a lot of complications. The primary pathophysiology is not solved with amnio infusion. It's only going to add on and trigger off preterm labor. It's going to increase infection chances, going to cause uterine rupture, cause harm. The only indication proven where amnio infusion helps is when a lady is in labor, there is meconium stained liquor, you want her to deliver vaginally and there is no place to do a cesarean, and we never work in such situations. In short, there is no role for amnio infusion. So 22 weeker, please amnio infusion kar do, matlab wo, it's suicidal for us because then we are going to put in a needle and she's going to deliver the next day. So please do not attempt amnio infusion in any kind of case, it does not help. Something that we do in amnio infusion, I've only done it once. There was this lady who came to me for the first time with anhydramnios, previous 2 babies lost due to multiple anomalies, and I could not assess the anomalies of the present fetus. And therefore, we did an amnio infusion only to do a scan, only for that much, because she was anyways going to terminate after that. And then we took out a fetal tissue for the DNA storage and we could help her with the prognostication of the next. So this is a very, very secluded kind of indication to do an amnio infusion. But otherwise, there is a whole list of complications that you have, which we really cannot afford. So a simple flow chart, AFI has been overrated. If there is a deepest vertical pool of less than 2 centimeters and you have assessed for rupture of membranes, abnormal Dopplers, baby is not small, there is no maternal disease and there is no reason for maternal compromise, are there any anomalies detected? Have you looked at the kidneys? Okay, you've looked at them, they are normal, okay, go in and give oral hydration. Wait, monitor, is it now more than 8? No, reassess. And that's how you go on, because if there is no other reason, isolated oligohydramnios do excellent. Okay, so that is a very, very good study, which is the RADIUS trial, and it's a huge number, 15,000 women they've assessed. Pregnancies with isolated oligohydramnios in the second trimester had similar perinatal outcomes as compared to women with normal amniotic fluid. The only statistically significant difference was increase in cesarean birth of women, which I don't need to say any further. So just to conclude, Doppler investigations give insight into fetal and pregnancy pathophysiology. Doppler can be used in all trimesters for different indications. It can be used as a screening or a diagnostic tool according to the circumstances. In the second and third trimesters, it can indicate abnormal placentation, fetal hypoxemia, anemia, acidosis, impending heart failure. When an apt vessel is used optimally at the right time and interpreted correctly, it enhances decision making for delivery and optimizes the feto-maternal outcomes. What Dopplers will you do on anomaly scan? I just forgot this one thing. Uterine you will do. Anything else? Any other use of Doppler on the anomaly scan? You can use it for renal demarcation, although that's not the right way to do it. But yes, heart, kidneys and uterine artery. So you need Doppler at every, in obese women, sometimes in the first trimester you just can't see the heart. You have to rely on the colors to see the heart. So Dopplers are really, really helpful as a surrogate marker for the evolving problems. So beauty lies in the originality, but change is the only constant. Technology is a boon when used judiciously in aptly indicated cases and with proper interpretation, without compromising on what is inevitable, and that's the mother. Thank you so much for the patient hearing. Thank you so much.
Thank you, Pooja. It was an excellent blend
Thank you.
of the most basic things which are very much useful for the beginners and the postgraduates in this audience, as well as the most latest guidelines and the changes which have come over the years. It's just simply good. Yeah, excellent. Yeah. Thank you. And in just one, you wish to bring up some points. There are certain situations where we have to give up and say that no, this baby is not going to survive and let it die. These are the situations also we need to bring, everyone should be aware of this. A situation like where the umbilical artery shows a reversal, the DV shows a reversal, there is a cardiomegaly, there is a tricuspid regurgitation, there is some fluid in the peritoneal cavity, some ascites, some pericardial effusion. So these are the babies who are certain to die. Even if you deliver them, say they weigh 800, 900 grams, 28, 29 weeks, and with this kind of Doppler picture, don't think of delivering these babies. We have to be bold about this and tell the prognosis that even if you deliver this baby, the patient would land up in unnecessary scar, and her subsequent pregnancies would become more difficult. So this is situation where we need to give up and not to just look at the Dopplers. That is what I think. That is one point. Excellent. And just to summarize the whole of the thing which we had in this session is we start looking more at the Dopplers. Uterine artery, the umbilical artery, the middle cerebral artery, and the ductus venosus. These are the 4 vessels we must remember. Now about the uterine artery, 12 weeks. You start with it. There is a tagline, Jindagi ke saath bhi, Jindagi ke baad bhi. Uterine artery with NT ke saath bhi or NT ke baad bhi. Okay. Then, changing concept about the small. Small is nothing small. It's a relative term. A 2.7 kg baby may be small for that particular pregnancy, for that particular patient. So the Dopplers will help us a lot in differentiating between is it really a small growing baby or is a baby which has not attained its potential and is going to face some problems. No, but the very important thing is about the intact survival. It's not the intact survival, it's the intact neurological survival. We need to have a reasonable quality of life when the baby is being born. If we are going to hand over a baby with a CP to the patient, there's no point in treating such a patient or delivering the baby. So we always look at this angle, whether this baby is going to have a reasonable chance of having a intact neurological outcome.
Any questions from audience?
Yeah. Any questions?
Very frequently now, but I just wanted to ask if we have the probability of downs and all this in our software of the reports. If everything is normal, like uterine artery, if NT is very low risk in whatever age may be there, still we have to do just for the sake of PAPE or overall? I mean, do we offer a blanket double marker study in a low risk after good NT scan if everything is normal?
Double marker is a universal screening and a standard of care now accepted. If you all start doing it, the lab will reduce the cost. Just think about it holistically. So I don't just work in Ruby Hall where there are paying patients. I work at Bharati Vidyapeeth, and last 4 years, when I joined there, they asked me the same question. And I convinced them it's not for low PAPE, only for everything. See, we look only at young mothers who are low risk and we call them low risk, and that's our perception. Have you imagined the number of women who are delivering below the age of 35? How many ANCs do you see in a day which are more than 35? Are they more or are 28, 29 years more? The younger ones. So the absolute number of women that are delivering in the age group of less than 35 years is way manifold more than the women delivering in the elderly age. And therefore the Down syndrome babies in numbers, in absolute numbers, are way more in the younger ones. And our NTs are not audited. All the NTs that are being are not audited. What is being to you is 2.2. It is normal. That is the radiologist's perception. That may really not be normal. And the worst thing about Downs is, unlike Edwards and Patau, Edwards-Patau, we cannot miss it. Nobody can miss Edwards-Patau. It will hit you on the eyes. Downs will be so subtle, and especially the mosaics, which are a little normal and a little trisomy 21. It's a mosaic of all the cells there. But they are so subtle that even with an NT of 2.4 and 2.5, the baby could have Downs. And that's where we use the double marker to give a combined risk. You told me that if the risk on scan is low, there is no risk on scan. The scan is done to give you the NT, NB, and the values of CRL. Then the scan is given to the double marker lab. The lab gives you the risk when combined with double marker. There is no concept of separate labs ka risk, separate ultrasound ka risk, and separate screening ka risk. Risk is combined first trimester screening only. Otherwise, at the end of the day, you will have 6 numbers. Priori age risk, NT ka risk. Priori age risk, double marker ka risk. Priori age risk, combined risk. You will only be confused. What will you tell the patient? So what we do is, whatever good the NT scan, so we've brought down the cost of double marker from 2,500 to 900 in Bharati Vidyapeeth. And I think 900, no couple will reviews. If you are convinced. If you are not convinced, then couple will not be convinced. But if you are convinced that the couple needs to do it, aajkal ke couples will do anything for the pregnancy to go good. So 900 rupees is really nothing, and it is helping us in a lot of things. There will be probably 1 or 2 downs will be missed in probably the whole career. For an obstetrician, for us, it will be probably more because we see only that. But that will really not be worth it because they live as much as we all do. They don't die. That's the worst thing. And the quality of life and more things are coming up with the legalities. You know, the kind of questions that the couples ask. If I'm telling them high risk on double marker, we do an amniocentesis and a karyotype. That day a couple asked me, why didn't you tell me that a microarray is available? We would have done it.
Oh, yes.
It is our job to tell them. तुम मेरे पास आए हो हाई रिस्क फॉर डाउन सिंड्रोम जो क्लियर हो जाएगा कैरियोटाइप में. But there is another test known as microarray which could tell us more. It costs way more, not required in this situation, but it will give us more information. Give information to the couple for which you are convinced about. If they refuse, take a refusal consent.
Yes.
That's it. A very subtle. You don't have to scare them away कि आपकी बेबी को कभी भी कुछ भी हो सकता है. No, no, no. A double marker was offered as a standard of care. The couple has refused. Signature, that's it. So you are safe with your OPD paper in future. Okay. Try to do double markers in everything. Do not give risks on ultrasound. Tell your radiologist to not give risks. Take the scan, give it to the double marker lab. Fix up one good lab, 2 or 3 good genetic labs. All of you start sending double markers, the cost will come down hugely. What do the labs want? They want numbers. Unka probe ka kit ka kaam hona chahiye.
I think the president will talk to the labs and we make all the SOGS members make a uniform.
That will be a very good thing to do.
This of sending the double markers by default.
Yes,
thank you.
Definitely, definitely. And it will be a very welcome change, and you will realize how easy it is to counsel the couples when you have those numbers. And tell the radiologist to stop giving risks on the scans, because it's really confusing. Technically, 10 to 13 plus 6 weeks double marker is allowed. So in the Western countries, double marker is first done, then the NT scan, but that's not the way we do it. In India, do an NT scan between 12 and 13 weeks and preferably on the same day send for a double marker. But ऐसा नहीं है कि अगर उस दिन डबल मार्कर नहीं हुआ तो अगले दिन नहीं हो सकता है. It is allowed up to the CRL of 84 millimeters. ओके सो अगर आज टिपिकली वो कपल बोलेगा डॉक्टर ने दिन भर बिठा के रखा, डॉक्टर सुमित इतने बिजी थे कि उन्होंने हमको 2 घंटा बिठाया, फिर बोला कि बेबी उल्टा है वापस जाओ, पूरा दिन हो गया हम डबल मार्कर नहीं दे पाए इसलिए हमने दिया नहीं, एंड देन यू टेल नहीं मत दो अभी क्वाड्रुपल देखेंगे. नो, give it tomorrow, because the lab is going to convert the double marker values into multiples of medians, which is dependent on the date of the scan. It is not dependent on what date you are taking the blood. Okay, so the lab is going to consider, a good lab is going to consider all these factors. So वहाँ आप typically देखोगे gestational age on scan, gestational age on sampling, वो सब रहेगा वहाँ पे. So don't worry, if you can't give the double marker today, give it tomorrow. Don't miss it. Quadruple sounds 4, but it's not better than double marker. Double marker is the best. And once you do a double marker, there is no indication of doing a quadruple marker. डबल मार्कर हाई रिस्क है, आगे बढ़ो एमनियो करो. डबल मार्कर लो रिस्क है, कुछ मत करो. बट नो यू स्टेपिंग डाउन द प्रोसेस ऑफ स्क्रीनिंग. एक बार बाईपास करने के बाद आके एंजियोप्लास्टी नहीं करते. यू हैव टू स्टेप अप द प्रोसेस ऑफ स्क्रीनिंग.
45 to 84, पर सबको मुझे लगता है कि 65-70 that is for our reason, because we'll get a good NT. So I feel everyone should advise at 65 to 70 where it's easy to get NT, and then we will not get frustrated and just leave it apart. So I request all the people.
Yeah, 12 plus 2 to 12 plus 4 exactly is the time, and over a period of years you and your obstetrician develop such a good rapport that even if it is a delayed conception, they start calculating and sending at that time only, and it is so easy. What madam says is really, really important. If at a CRL of 45 millimeters, I never do an NT scan at this CRL, I will send her back. I will show her the FHS, I will fill the form, but I will not give her an NT report. I will not charge her. I will tell her, please come back in 10 days. Presuming that the baby is growing at the rate of 2 millimeters per day, I will try to reach 60 millimeters and then call her. Kyunki kya hoga 11 weeks pe? Nasal bone not formed, ductus reversed. It is supposed to be like that at 45 mm of CRL. And then you go in and do a CVS, a NIPT and blah blah. Not required. You call her in a week's time and everything normalizes. This is so common. So doing the right thing is always right, and you can do it anytime is not correct. You have to do it at the right time. Just doing the right thing is not enough. Same things hold true for 84 millimeters. Suresh sir calls it term NT. Term NT मतलब वो बेबी ही नहीं दिखाता है कभी NT. It is constantly in an extended position and prone. It never shows you a good NT, and you are so frustrated then. Best time to do it is 60 to 70 millimeters. Good anatomy, good aneuploidy markers, nasal bone formed, and good assessment of everything. And a good time to do double marker also. So this is an optimum time. That's a very good point brought up by ma'am.
Ma'am, is there any time difference? We do NT and we do the double marker.
As long as you do it before 84 millimeters, no.
What happens is that we send for NT, but patient comes back after 4 days or 5 days, and is it okay if we do it after 4 days or 5 days?
Yes, absolutely.
Calculate. अगर NT scan किया है उस पे CRL already 80 millimeters हो गया है, Calculate 2 millimeters per day the baby is growing. So will you be able to give blood double marker after 4 days? No, because 88 millimeters ho chuka hoga. So we do get calls from obstetricians. In doubt, call your radiologist, call your fetal medicine specialist. They will guide you. Because rather than doing a double marker at 14 weeks and 2 days, do a quadruple at 16 weeks in case that window has been missed. The only indication of doing a quadruple marker is for a late booker or such situations.
14 weeks, the values you don't get accurate, the beta HCG moms and this. So you get a false report.
It is
if the gestation age after 14 weeks, you are not supposed to send. I think
between 14 and 16 weeks is a dead time for any assessment of anatomy, aneuploidy, nothing. It's just a dead time. Don't do any maternal biochemistry, no scans also. Don't even try to go in and scan. Because जो 12 weeks पे था वो जा चुका है और जो 16 पे आने वाला है वो अब तक आया नहीं है. So wait for those 2 weeks. Those just don't do anything. And in fact, beta HCG and PAPE, the earlier the better. But in India, that model, I mean, I personally practice that model. जो regular referrals है मेरे doctors, they give the double marker at 11 weeks. They come for a home visit, double marker चला जाता है. 12 weeks पे the lady comes to me at NT scan. By then, my email already has their double marker values with me. I scan her, I add the double marker absolute values. Lab doesn't give the report to the patient at all. Lab gives it to me. And they don't give me moms, they give me the absolute numbers. In my software, I enter those values, I enter the NT scan, and only one risk goes to my patient, and that's the one I'm giving. So this is the ideal way that we've been taught when we were training in London, but it's not feasible for everyone. But the best we can do is, aaj NT scan, jate jate double marker de do. Make sure you don't do a double marker if the scan is abnormal. NT 3.5, don't waste money on the double marker then. So if there is a problem on ultrasound, don't go ahead and do a double marker. If the lady is bleeding, don't do a double marker. If there has been a vanishing twin, if you can see the fetal pole on scan, don't do a double marker. If she has received HCG injection in the last 5 days, IVF patients, bleeding, आया, Hucock दिया, अभी Hucock आपने दिया, बाहर जाके double marker दे दो, वो HCG high आने वाला है उसका. So don't do the double marker in such situations then.
Second trimester, they have the same outcome. How can like 18 weeks pregnancy with AFI, some mark, like suppose
they
AFI 3,
isolated
4,
mild oligohydramnios, mild, only mild.
Only mild.
Moderate and severe will usually not be isolated.
Yes,
they will have something.
But mild was not written, so I was confused. Like
mild, Cochrane वाले slide पे mild लिखा है, but पहले वाले पे नहीं लिखा है. You are right. But there will never be a severe oligo without any other reason. या तो leak होगा, या तो renal agenesis होगा, कुछ तो होगा.
And one more, it's like not related to this thing. Many of the times, like where we practice, there they give isolated echogenic foci or isolated calcified foci in the left ventricle, and that too at 16 weeks. When NT was like normal, everything we did, what to do and how to convince. Many of the time we convince patient, but still like
So
do we need to do quadruple test?
If you have done a good NT scan and a double marker and your risks are low, the heart looks fine, there are no associated markers, echogenic focus can be ignored because 3 out of 10 normal Asian babies will show an echogenic focus. But you have to be sure everything else is fine. If she is a late booker, you've never seen her before, she's not had an NT scan, she's coming for the first time, there is an intracardiac echogenic focus, any which way you have to do a quadruple, even if she doesn't have an intracardiac focus.
Okay, so just doing first visit and we
it's
find
a very
it.
minor marker. If the heart looks structurally fine and there is no associated aneuploidy marker, it can be neglected.
Only quadruple test will do along with.
Yeah, if double has not been done.
Yeah. Thank you.
Double is the best.
Yes.
Well, bringing back to the double marker, it's very ideal to do it, provided the double marker is done in the most ideal way.
Yeah.
In our country, the major problem is the processing of the sample. If you look at most of the people who offer the double marker, don't tell which machine they have used.
Yeah.
You know that they're the only 2 machines. What's the name? They are supposed to use, and those are calibrated and are recommended. Those are recommended by the FMF. That is number 1. Number 2 is the quality of the kit. Those all come from China. We don't know the standardization of those kits. Number 3 is the transportation error. See, most of the samples, like in city from Solapur, they collect. It goes on the 3rd day in the laboratory. It's processed on the 4th day. The, during this transportation, the PEPE would go low, the HCG will go up, and then you will have the false positive. That is what I have come across in many patients. My false positives used to be very high, and the unnecessary invasive tests or NIPT was the experience with all these.
Yes.
And that's the reason now I have stopped doing the double markers.
So did you try to change the lab?
My NTs are with, of course, audit. I use the NB, the DV, the nasal bone, and all those in the risk calculations, and they work better than the double marker. Double marker creates more confusion. That is what I believe. Yesterday only I came across a patient. Afternoon 2:30, she gave a sample at a taluka place, interior place. Same day, next day afternoon, she received the report of the double marker. Is it possible?
Sir, which is why I
And
kept
this
saying
lab,
from a correct lab.
this lab is from Delhi. Will you get a report collected in the afternoon,
Impossible. Yeah.
processed, and next day afternoon it's in your hands?
Yeah.
These are the kind of things which are happening around us, and we have to, if we wish to go ahead, we have to do all these things. What I expect is the laboratories, if we are going to tie up with them, they must give the audit, they must give the false positives, they must give the true positives.
Correct.
Then only there is a sense in doing such kind of tests. Otherwise, it's going to increase the unnecessary invasive tests with its related morbidity, because as a senior obstetrician or fetal medicine, I've been receiving a lot of such positive tests and going invasive for last 5-6 years. And then I realized that these are all false positives because of the technical errors.
So, sir, there are 2-3 ways. What you're saying is absolutely right. There are 2-3 ways of reducing this confusion. Number one is the lab and the scanner has to be audited. So, there are excellent labs who will not include the NT done by a non-audited scanner only. Such labs have to be chosen. Only then the standards will be maintained.
Tell me the name. There is no lab who gives up the business.
So I'll mention 2-3 labs that I always, and the patients ask me, Metropolis itna acha hai, Golwilkar itna acha hai, AG, they are really excellent labs, but they are good for urine and sugar and thyroid. A lab that is doing all the tests for all the age groups and receives one double marker in 3 days is not going to do it as meticulously as a lab who does only double marker day in and day out. Okay, that's the explanation I give, and I always give the option of 2-3 labs. I mean, not favoring any lab, but excellent experience over last 11 years with Lilac Insights, LifeCell, Anderson's has come up good, Perkin-Elmer is good. These are 4 labs, and the way of reducing your false positive is that you add NT to it. If you just tell me, sir, of the all false positives you've got, how many of them do not have NT included in it? Because if a normal NT scan and false positive double marker, it's because the NT is not audited, and that's why Lilac does not include all NTs. It will only include an NT from an audited scanner.
Also, the scenario is that they come after 14 weeks with this report.
Yes.
How you're going to look at the NT. The NT is already
true.
done in the...
and it has not been included in it.
It is included. But then the NT image itself does not meet any of those FMF criteria or the
It will
Harman
take
criteria.
time, sir, but we need policy holders like you and seniors like you to guide us and encourage us to do things, not just the right things, but at the right time in the right way, so that all of us can work towards a better goal. It will really reduce a lot of unnecessarily terminations and a lot of problems like that, yes.
Thank you, ma'am.
Any more questions?
Okay. I request and Jama ma'am to please felicitate Dr. Pooja ma'am. Chairpersons. I request Dr. Sadhna Deshmukh and Baldava sir, please Sumit sir, Ajit sir.
Thank you everyone. Thank you Dr. Bijoy sir and Dr. Pooja madam. From bottom of my heart, your presence and wise words helped magnify our course in the best possible way. Special thanks to Dr. Ajit Gandhi sir and Sumit sir, our chairpersons, for gracing this CME and invigorating our knowledge. Today marks the first clinical meeting of our 2022 and 23 team, and we are proud to be able to host it today here at this wonderful place with all of you. I would like to express my sincere appreciation to all of you. Lastly, I would like to thank you, our Sun Pharma partners, Mr. Swapnil Aher, Mr. Nitin Zadav and Mr. Anand Patil, who generously helped us making this event come together to become a success. Thank you everyone. And everyone please join us for a delicious lunch. Thank you. I request Mr. Swapnil Aher, Mr. Nitin Zadav and Mr. Anand Patil, please